how we make decisions and how we govern this wide area of importance. So why are we doing this? We need to ensure coherence in the implementation of the health policy of Tanzania. Like I've said before, I think it was a plan used by Tony Blair when he was in position, and it's also used by United Nations Department of Economic and Social Affairs, where every entity that is responsible for governance, it has its own mandate, it has to make sure that it contributes, and then you have a sum total of contributions of each mandate. Now for us in health, I was thinking we need to use this approach because health is cross-cutting and all government ministries are related with. So for us now, our concern is the two ministries. And now I'm thinking about maybe it's not just two ministries. We also have to have the Minister of Community Development, where I think health also is cross-cutting. In addition, to maintain health, in bracket preventive programs, and also curing the sick in health facilities, it needs involvement of more than one profession. I mean, we all including in this. The shared governance is necessary if we are told to achieve the universal health coverage. So why now? We know that the burden of healthcare is on a steep incline. We now have NCDs which are really taking a lot of the health workforce, re-emerging epidemics, new pandemics, and we need to make sure that everyone has a broad sense of competencies in order to combat this. So the shared governance and the implementation is important, and hence we are suggesting that we should adopt a whole professional approach. Why am I saying this? I think today we've been talking about optimizing the nursing. Catherine was talking about it, Dr. Farad has asked about it. I think we have not made 100% use of the nursing workforce. That it makes up about 60% of the total health workforce in the country. So we're not leaving other professions, but how do we make use of these nurses? In the nursing governance, there's what we used to have a card model of nursing governance, where the nursing education unit, which is under the Ministry of Health, is actually producing the health workforce. We now have diploma and certificate nurses who are under an activate, that's a different ministry, I mean that's a regulatory authority. And then we have the universities under TCU. These are the key producers of the health workforce, and when they produce this healthy workforce, they are regulated by the Tanzania Nurses and Midwives Council, which gives them certificates and license to practice. And the TNMC has mandated to make sure that the public is actually receiving good quality care and they're not harmed by the services provided by these professions. And then we have the professional associations. Now these have a mandate to protect, fight for the rights of the nurses and midwives and all those affiliated with nursing. They've been a little bit silent now, we have not heard them. And then we have the Directorate of Nursing at the Ministry of Health. The Directorate of Nursing is actually the consumer of all the product that is being developed. And we feel that we have now quite a huge number. I do not have the statistics, but what is really important is in the last 2 decades to date, the nursing profession has grown so much to have clinical nursing specialties, various PhDs in all other sectors, not just in nursing. Yet we have not used all of this workforce to man the underserved populations. And I think we also need to develop collective responsibilities in each profession, each to support and not to oppose, so that we can actually give the care that is needed. We do have nurses manning almost everything within the underserved societies, but they're not protected. If anything goes wrong, that nurse will be liable for whatever it is that they have gone wrong. But we need to formalize them and protect them and give them responsibilities. Once we give someone a responsibility, they will be up on the goal and they make sure that will deliver. Recognition is very important. You saw Catherine's presentation, the nurses jumping up and down because they received received an award. And now that is recognition, and I think in all humans, recognition is very important. So the shared governance. It's a professional practice model that promotes shared decision-making in nursing empowerment. It involves making nurses accountable for decisions that impact processes, policies and procedures at the point of patient care. What are the benefits? Shared governance leads to improved collaboration, engagement, and better patient outcomes, and that's what we're looking for. We have certain principles on that. They're quite vast. I want to speak each of them, but then practice equity, ensuring fairness and equity in practice, ownership, accountability, empowerment, leadership, innovation, autonomy, and team building. I feel that at a certain point in time we have lost some of these key principles of shared governance. Maybe at the national level we need to go back and look what really is not going right and we need to correct that. And I think with the collaboration that we have with the UK agencies, we hope that it won't be just Prince Hospital but other NHS trust hospitals. The future, I don't think I'm in a position to say the future, but we're going to discuss this. Thank you very much for your attention.
Thank you very much, Dr. Hadiya, for a very good presentation. Now I would like to call upon Dr. Joseph Mwanga on his talk on the burden of motorcycle injuries in Tanzania, experience from Major Trauma Center. Dr. Mwanga is an orthopedic surgeon and trauma surgeon, head and director of the Department of Orthopedics and Trauma at Mobile National Hospital. At MOAS. He has been employed by Mobile Orthopedic Institute. He's an AO Trauma and AO Alliance faculty. He is also an AO Alliance chairman of the Steering Committee for Sub-Saharan Africa. An area of expertise, he is into complex trauma, pelvis, and acetabular surgery, and arthroplasty. Welcome, Dr. Mwanga.
Thank you very much, Humba. It has been a good time to meet you here. So I know it has been soft since morning. You know, what do I mean? Soft landing. But now I'm going to the hard landing. So when you talk of the burden of the motorcycle injuries, I think you'll bear with me, those natives who are living here in Tanzania, specifically in major cities. So as I was introduced, I'm privileged and I'm honored to present you to this congregation. So thank you very much for allowing me to do that. So the outline of my presentation, I'll start with the introduction, then I'll talk about the burden, followed by the challenges that happen during the management of these injuries which are caused by the motorcycles. Then also talk about the areas of collaboration, and I'll finally give the summary. I was saying it's a hard landing. Why? These are the type of injuries that we see. Sometimes we ask ourselves, are we living in a war region? Are we in a war? Is it a blast or something more than that? So these are the daily injuries which we get from our major trauma centers. I don't know about the district hospital. I think they get the same if those patients manage to get there. So as we know that 4.4 million deaths, they occur from injuries worldwide, but 30% more compared to other diseases. But also, it is known that 40 million injury-related deaths and deformities, they occur worldwide. And bad enough that 90% of all these, they occur in low and middle-income countries, Tanzania inclusive. And if we look at the budget, national budgets, it's only 1% of the development fund is directed injuries compared to other NCDs, which goes up to around 40%. So let this open up our minds. So why do we say it's a burden? Because there's increased use of motorcycle as public transport. We see because of the road congestion, so we tend to go a little bit faster to reach our work destinations. But also because of this, we have a very high number of injuries and deaths, especially in urban areas. And most of these injuries, that's why I showed you the first snapshot, that they tend to be of very high And when you talk of very high energy, that means the effect is more than what we think. And this leads to high death rates with permanent disabilities. So we've gone through the evidence of 6 months from only three centers. And we found that there's increased number of polytrauma and mangled extremities, which are associated with high injuries. And this is seen also. There's a very high increase in number of pelvis and acetabular injuries, which indicates that these are very high energy injuries. Then also, we found that the data which is in the hospital does not tally with the data from the police. We know that police officers are the ones who are the first one to see the patients at the scene of the accident. The data you find from the police is different from what you find from the hospital. There's no tallying between these two. But interestingly, little is known on the outcome after injury. We all know that 90% motorcycle crashes, 60% cars, but what is the outcome? Nothing much has been published on this area. So one of the centers which we took the statistics for the past 6 months just to find out whether this is true or not, that's Mbeya Zonal Regional Hospital. In the past 6 months, they attended 1,416 cases of trauma, and 83% was due to motorcycles, okay? And out of that, 18% were the major trauma. You talk of the open fractures, polytrauma patients with chest injuries, with mangled extremities, and all those you can mention. But if you go to Moi, you find that out of 3,531 trauma cases, 70% were from the motorcycle crashes. But we found that there are more than 42 deaths on arrival. We found that these are the patients who stayed somewhere or they came direct from the scene of the accident, 42 deaths on arrival. But managed to operate 805 patients as an emergency, and most of them, their lower extremity injuries. And as you saw that 70% were from the motorcycles. Again, we took a snapshot on the Dodoma Regional Referral Hospital. We found that also 72% of the injuries for the past 6 months is motorcycles, with 149 deaths. I may pause there and ask, do we think this is normal?
No.
It doesn't look to be normal. It's something that has to alert our minds. But I went to the evidences. In 2019, there's a paper which was published by our colleagues, that is Henry and his colleagues, and this was a burden of road traffic injuries in Tanzania. That was prospective study on consecutive patients in 13 multi-level health facilities. It was found that 68.5% of road traffic injuries occurred in urban areas, and 68.3% motorcycles. So this shows that there's a burden, there's an increased rate of that. And in those mitigations which are always advocated by us and the policemen, only 37% were putting the helmets on the time of the crash. But this paper did not address the outcome after those injuries. We just saw the numbers. But I went down and found another paper which was published by Billy Haonga et al. This was the burden of femoral shaft fractures in Tanzania. But this still showed that the high rate was from the motorcycle crashes. This was on the femoral fractures. We just went down and checked on the femoral shaft fractures, the burden, and we found that most of those patients were referred to other centers, to other major centers. Why? Because these hospitals could not manage because of the implants or presence of experts. And barriers to surgery were also identified at that time. But still there was another paper. They decided to go down and check on the cost of intramedullary nailing for femoral shaft fractures in Dar es Salaam, Tanzania. The same that was Billy together with his colleagues. And they found that there was a very high cost of treating a patient with femoral shaft fracture. They went down and checked and found that, again, the higher percentage was from the motorcycle crashes. And again, they found that there was a very good, very huge range of time of stay to the hospital from 4 days to 92 days. This depends whether this was a polytrauma patients, bilateral injuries, or with other associated injuries. And the cost was approximately to be around $530.87 US per each patient. This is just a minimum cost that the patient can spend in treating him or herself. So this is just a snapshot on the costs and time to definitive surgery. And also, this implies that there's an overall impact in the economic activities in this country. Why? Because if you look at these data which I've just given, most of these patients are the young generation, the productive age, and high percentage males. In Tanzania and in Africa in general, males were the ones feeding the family. So imagine all these, they run into those issues. So what are the clinical management challenges? Diagnostic facilities. We see now there's a lot of improvement in diagnostic facilities. Well and good, but who interprets those images? Who make decisions after those interpretations? How about the quality of emergency care, which has been spoken? I'm sure other colleagues are going to talk about. Is it improved? Because if you don't have first hour at emergency, good management of these patients, we end up in disabilities and mortality. How about orthopedic theater facility? Do we manage all these patients with this volume? Do they get proper treatment? Yes, they get, but at what level? How about availability of experts? Because motorcycles, they're everywhere in this country. The accident you see in Dar es Salaam, they're saying in Mwanza, they're saying in Malampaka, and everywhere in this country. So we have available experts. Yes, for now, we have at least in each regional hospital, we may find 1 or 2 orthopedic surgeons. But do they perform and treat these patients? Then how about the severity of injuries? Nowadays, we tend to see polytraumatized patients. More than one system is affected. I remember the time I started working in Moi 18 years ago, we could see only one pelvic fracture in 3 or 4 months. But nowadays, in a weekly basis, we can operate 4 to 6 patients with pelvic fractures. How about shaft fractures? So this looks to be like it's a challenge that needs to be addressed. How about the potential sequelae? Okay, there's an increased burden to the referral system. Why? Those hospitals which cannot manage polytraumatized patients, that cannot manage those complex injuries, they tend to refer these patients to our hospitals. But sometimes patients may fail to reach the hospital at a required time, so they tend to have more complications. How about overwhelmed experts? How about increased mortality and morbidity? Mortality and morbidity, as you have seen in the data which I've given you, is relatively high. And also, it is very expensive to treat complications. Such a patient like this presented 6 months posterior dislocation of the hip. So this one may have a lot of complications. Such a fracture. This is osteomyelitis. Patient was at home, treated, and went to the hospital. When referred to the center, they never come. So they come when it is late, and we spend more time, more expenses in treating the complications. So what are the areas of collaboration after talking about all this data, all these problems that we have, and the improvement that we have had for the past years? So we need to have local improvement, especially the facility improvement. We need to improve the facilities that are treating these patients. And this is countrywide. It's not only Dar es Salaam, Morogoro, or Dodoma, because all these border men, they are everywhere in this country. Then also, local capacity building through fellowships, trainings, and research. Let us collaborate with the universities. Let us collaborate with the hospitals which have a full capacity of treating these patients. And also the most important thing is preventive measures in collaboration with police force. Because without preventing these injuries, we're going to have a nation that has crippled individuals who spend a lot of money treating the families. Imagine a man like me with 5 children, and I stay in the hospital for 3 months. What will happen to the family? And I'm the one who provides everything. Then also we need to have a synchronized data collection or data keeping, because things don't tally. The policeman will tell you this data, the hospital will tell you this data. More will tell you we have this data. If you go to Temeke, it's totally different from what we have. So external collaboration, we are thinking that we need to have capacity building, specifically on research, because we have a lot of hidden information from what we have on the ground. And also we need more experts in tissue reconstruction through fellowship programs. Could be reverse fellowships or could be our fellows to go to those centers where they can train them. Then also the complex skeletal injuries, as we saw that the burden of the complex skeletal injuries is increasing. We need to train more people, especially in the hand and microsurgery, and also the equipment support. Because with these complications, with this type of injuries, we cannot treat these patients without equipment. We need equipment, we need implants, we need skills, we need everything so that we can tackle this problem. So in summary, that let us know that trauma is a neglected epidemic. It's a neglected epidemic. And the motorcycle injuries, they dominate in low and middle income countries. And there's very high morbidity and mortality rates, and workforce is highly affected. Hence, the economy is also affected. So there's need of reinforcement in mitigation so that we avoid all these problems. And we start to find the outcome after trauma is very important, because we don't know after the trauma, where do they go and what's the burden to this country. So thank you very much for listening.
Thank you very much, Dr. Manda. You landed exactly what we expected. Thank you. And now I would like to welcome Dr. Erasto Silvanos for his talk on countrywide establishment of emergency departments and future of trauma registry. Dr. Erasto is an emergency medical specialist and a health emergency disaster management expert in the Ministry of Health at the Emergency Preparedness and Response Unit. With various experience, has worked as a case management and AMP at IBC Technical, is a pillar lead during the health emergencies and disease outbreak for 3 years. Dr. Erasto has also coordinated and established, coordinated the establishment of regional and council emergency departments, equipment, and countrywide emergency care training. Karibu, Dr. Erasto.
Thank you very much, Dr. Wumba, for a very generous introduction. And after the hard landing that we have had, I'll take you through some of the areas that we can address some of those issues, but the gap that is still there to exploit and to work on. So, after COVID, apart from the challenges that we faced because of COVID, we, as a blessing as well, we revolutionized some of our medical services. In 2010, we had only one emergency department, and it was only at the National Hospital at Muimbili. And this is the building at Muimbili then. But after few years, of course, we had establishment of another emergency department at the zonal hospital, Bugando. Then we had another one in KSMC, Moshi. There was another one in Dodoma and Mbeya. So we had those at the tertiary level. And we had very limited emergency departments at the private sector, like Aga Khan, Rabininsia, and where else? Regency, etc. So at the public facility, we had very few emergency departments. Following COVID-19, a lot of patients were coming to the emergency department saying they needed oxygen, they needed critical care services. So we had a big challenge, a quick one, that we needed to strengthen our services at the emergency care settings and also at the intensive care services. So we established new emergency departments from the level of primary health care, where we are at the level of district hospital. We have established 82 new emergency departments, and at the level of regional hospitals, we established emergency departments all of our regional hospitals. Of course, we also went up to the sub-specialized hospitals like Moi, Mirembe in Dodoma. So we had established emergency departments in such specialized hospitals. So up to now, we have these kind of emergency departments at the district level. So they are as beautiful as you can see. We have some. These were only seen at the national level, but we can see these beds at the district level, at the emergency department. You can see monitors, you can see ventilators, you could see such things that happen. And we have bought, as the government, ambulances. These are new ambulances, around 605, of course others will come later. But we had other stock of ambulances that were running in country. So we are having a pool of over 1,300 ambulances there with the emergency department that we have installed. Then the emergency department that we have established have their demands as well. Becoming you are punished by your own success. You need to also improvise and feed the emergency departments. But we have a very low output of training. We have now we have two in country training institutions. We had Muhimbili, Mohas, and now we have established another one in Kilimanjaro. But you could see from this graph, these were the number of trainees in local production. Like there was no time where we reached 20. So like 10, 8, 4, 12, but others were trained elsewhere. So in total for all these years since 2013, we are around 95 or something. But half of them are not practicing in our facilities. They're either out of the country or they are engaged in private issues, not non-clinical issues. So that's the gap. So we still have a gap of human resource to man the emergency departments at all the levels that we've mentioned. And of course we collaborate with partners for training. Short courses, we think maybe for all 3 years or 4 years of training, we could impact short courses, skill-based training, like 2 weeks training only to how to administer oxygen, or how to do advanced life support, or to do trauma life support, such things. So we thank the universities, the professional associations who are doing that together with the government to cover the gap. So the challenges that we have in essence from the establishment of all these investments, we still have a human resource for health challenge at our emergency departments. Of course, it goes all the way to all the areas of emergency care, or health care. There's a gap in nursing in every department, gap in surgeons, gap in physicians, everywhere. But because we have created this emergency departments, we wanted to have the impact that was foreseen. We understand that when we have very good emergency services, that it can affect the overall outcome of the hospital. The studies say around 40% of the overall hospital mortality will go down. So if we can maximize these services across the country, we can really help. Even the hard landing that was talked about here can be a little bit softened from there. So we need to do that. We also have a big challenge of leveraging the presence of ambulances, presence of emergency departments into the emergency medical services out of the hospital. How can we link those. Now can we link the family medicine that that is being talked in the morning to collaborate in the overall outcome of patients. So we still have challenge of limited training in these areas: clinical care, emergency care, super specialization as well, availability and sustainability of these equipments, fancy equipments that are down up to the level of health, or the level of districts. And another big gap is the data that we collect on daily basis. We are not poor on data. It's how are we using the data that we have. We have a lot of data, and having all these centers could also help us collect more data. But how quality are they? How useful can we make out of them? That's the gap that we can collaborate and see how we can do. So the potential opportunities that we have right now is a political wing. We are very thankful for the government that is very positive about improving the healthcare of all Tanzania. So we can tap into that right now, and we can move everywhere as we want. Our teaching hospitals and mentorships, we need to also consolidate there. We collaborate with our partners in the UK, see how we can mentor our teams. We can support them with short courses, specific skills to build them towards a better healthcare. Lots of data for research. We can see how we can use them. The trauma, which I'm going to talk very soon, the trauma registry. All those things we need to leverage. And in this part, the out of hospital emergency medical services, I said I would hint a little bit from the question that you asked. We have planned to establish a formal national emergency medical services. Right now, we have selected services in hospitals, facility-based, or some of the small organizations that will just be localized maybe in Dar es Salaam only, private driven. But we need to have to go across the country because the emergency medical services needs to be public, and it is very costly, so it needs support of the government. So we need to link all these ambulances. We have already bought some car tracking systems in our ambulances, so now the ICT teams are building that system, the ambulance dispatch system. So we think by the end of this year we'll have a complete ambulance dispatch system that is linking all these ambulances. And then we have a system of putting data when they take care of patients from the community or from facility to facility. All that is taken care of. But we started from a small point where we started with mama alone, called a mama if you've heard, because we had no ambulances, we had no teams. We could just transport women, pregnant women, from one facility to another, but we couldn't cater for, in a coordinated manner, the road traffic accidents, strokes anywhere, and such emergencies that we could know. So we think we need a trauma registry in place. Our ICT teams have also put already in emergency health, emergency medical, electronic health management systems. They say by July it will be live across the country. So that will also help us in the data collection. It is structured in WHO format. It was just adapted a little bit, but it will capture all this data. That will answer some of the questions, like what really hurts us, like some of the answers we have, the motorcycles, the source of these injuries. Who is getting hurt more? This is a group of the young, or the old, or the men or children. Then we need to know what the outcomes, because that is also missing. We can't find the data. All the data are in silos. We can't tap the data to have national data. We have to ask every hospital separately. So these systems will help in the estimates of the costs, overall costs of each trauma case, and we can see where to improve in the whole spectrum of where patients come from the scene up to the hospital discharge. That thing, or that system, will help us gather those data. So we have this data, monthly or quarterly. We have our systems that can collect data monthly and quarterly. So we want to synchronize with the data that can be pulled from our national trauma registry. And then what we anticipate in the future, we think future is bright. If we work together, use all the resources that we have, all the friends that we have, and fill the gaps that are existing. So we need more initiatives. We need to establish this system and run it. We have all the legislature associated with them, the clinical care guidelines, the teams, what we call the paramedics. We don't have the formal paramedics in the country, but we said we could start in 3 phases. The first phase right now is we are going to use the existing nurses and doctors who are in our hospitals. They will have a schedule that today, ambulance will be served by so and so. So they will be running in the ambulance. When you are called from the system, they will go serve. And then the second phase will be the community health workers. Right, they've started this month the training, 6 months training. It's preventive and some of the curative services that they are doing, and the promotive services. They will have a task of, after this training, they will know how to do the first aid, and they can transfer safely patients from the point of from the scenes of point of injuries, or even from homes, depending on the situation that he has, and then they send them to. The third phase is the formal training of these paramedics. This is cooking. The MUHAS has already completed the curriculum, so I think when it is done, people will start going train, and we think we'll pick people from Form 6 or even Form 4. Those who are interested will go and study, and then their pathway will go, like if they want to go to nursing, they will do nursing. If they want to go in medicine, they will do clinical services, depending on how their path is going to be. I'm left with 1 minute. Okay, so I think we need more collaboration in the research and have data-driven innovations in this area and even beyond, because we are here. We can see how we can improve this part and how we can do better in these innovations that we are putting forward. The trauma registry, the emergency departments that we have, and linking them with the critical care services that are across the country. Thank you very much.
Thank you very much, Dr. Erastus Silvanus, for this very good presentation. May I now call upon Dr. Lemery Nchome, who will give us a talk on brain tumors in Tanzania. As he is coming, Dr. Lemery Nchome is a senior neurosurgeon at the Department of Neurosurgery, Muhimbili Orthopedic Institute. He is a lecturer in this very department of orthopedic trauma and neurosurgery, University of Muhimbili of MUHAS. He has been employed with Muhimbili Orthopedic Institute for over 20 years now. His main area of interest and expertise is brain and spine surgeries, both microscopic and endoscopic, and he has some specialty in epilepsy surgery. Dr. Lemery Nchome is currently the acting executive director of Muhimbili Orthopedic Institute. Dr. Lemery, you're welcome.
Thank you, Dr. Anton, for the introduction. Good afternoon. With regard to this collaboration with Tanzania and TUHEDA from UK, I thought probably we will talk on the generally on cancer management. But it came out that we should speak about the brain tumors. So I know most of the people here in this room, they are not so much used to treat brain tumors, so maybe a few people will understand me. Yeah, so my presentation it's not only from MOI. This is a presentation made in collaboration with other institutions, tertiary hospitals, and particularly Loganzila, as well as KSMC and Benjamin Mkapa. So we used the data from 3 hospitals, and the aim of this was just to check on the burden and the challenges in the management of the brain tumors in our country. So I'll just take you through just a few data we have and what we have done, and to see the existing gap so that we can compare with the practice in the UK in the coming presentation. So from January 2022 to January 2024, we operated 465 patients with the CNS tumors. And among these patients, 82% of these patients were above 18 years. They were adult, and the majority were males, by 52%, not so much. And 83.9% of these cases, it was the first surgery, and 16.1% it was second surgery. And talking about the location of the tumor, you can see 50% it was, there were supratentorial brain tumors, 108, that makes 23%. It was infratentorial brain tumors, and 92 cases, which is 19%, almost 20% it was spine tumors, as well as the rest were just a small percentage, 2.5 and 3.9, and the 2.5 was intraventricular tumors, and the scalp and the peripheral nerve tumors. We had available histopathology result of about 81.9%. This means that 18.1% we could not get histology information due to various reasons. So among these patients we had histological result, 34.8, these were meningiomas, 21.1% were gliomas, and the 11.4 were stranomas, as well as ependymomas constitutes about 6.5%, and 8.8%, these were other various pathological subtypes or types. On the same institution, previous 19 months before commencement of this that I've just given here, you can see we operated a total number of 367 patients. And this was only brain tumors, does not include the spine or peripheral nerve sheath tumors. And among these patients, now you can see on the histological diagnosis, the meningioma again was number 1. I think this is clear, it was about 53%, and the gliomas was constituted about 25%, and within this, glioblastoma multiforme was constituting 30%, and the primary pituitary tumors 15%, craniopharyngioma 5.4%, and the medulloblastomas 2.9%. The data from Kilimanjaro Christian Medical Center, this is KSMC, ranging from 2022-2023, they operated in the Department of Neurosurgery in that particular hospital. They operated a total of 658 cases. And among these cases, they operated 80 cases were CNS tumors, which constituted about 12%, of which 69 cases were brain tumors, and 11 were peripheral nerve, or spine and peripheral nerve tumors. In this number of patients they operated, only they could get 45% histological results. So you can start to see where is the problem. Yeah. The most common diagnosis which they had in those 45% which they could be able to get the pathological result. It was meningiomas, again, which is 51.7%, glioma, 25%, and others, I think these are other histopathological types, which constituted 22.5%. So this is just in a glance on what we encounter on daily practice in different institutions in our country. This data belongs to these two hospitals or institutions, but we don't have more data from Bugando, it's on the Northern Lake Zone, from Benjamin Mkapa, as well as from Mbeya. So if you have all this data in one place, you can see the burden in real picture. So what do we have? Because in order to make, I can say, effective surgery, you need to have equipment and experienced surgeons and other things, supportive care, which is important to achieve the desired goals. So what do we have in the operating resources? I'll talk on MOID. We have high-speed drills. These are craniotomes. We have intraoperative ultrasound, which we can use at any time during our surgeries. We have the intraoperative neural monitoring, but this is mostly for the spine surgeries. We have a navigator brain lab, again for spine surgeries, not yet for the brain. We don't have a software for the brain surgeries. We have the endoscope where we do the transnasal pituitary surgeries, and we have the ventral microscope, which we use on a daily basis for performing our surgeries. So, based on the type of cases we are seeing in Tanzania, we have patients who come with moderate, smaller tumors, but majority of the patients, they come with extreme disease. And some of these cases here we show, these are examples of extreme disease we face. And this is because of the, I think, referral system from the different, from the lower levels to the higher level, but also socio-economical status of our patients to be able to travel all the way from where they are in the remote areas to come to Dar es Salaam. So just this case, this is a case with the supratentorial meningiomas, meningioma which had a abnormal radiological appearance. Initially we could not tell whether this is meningioma or not, but during the surgeries, it was found that it's a meningioma calcified one, and we managed to remove 100% of this tumor, and you can see the control CT after the surgery. Again, as I said previously, we see extreme tumor sizes, like this one here, which we were able to remove the tumor, but we had to struggle closing the wound because of most of the skin was involved in. So we have to try to do rotational flaps to make sure that we cover the brain, and later on to do the cranioplasty. This is some of our setup. This is in theater. We are preparing some of our patients, and you can see some of our surgeons there operating. You can see they're operating here, and this is posterior fossa. They have removed the tumor. There's a complete removal of the tumor in this child. It was a case of a child. And we also, as I've said previously, we also do the transnasal tumors. You can see here, this is a tumor in the pituitary region. It's a pituitary tumor here. And this, we are doing surgery with endoscopy. And after the surgery, this is the control image. You can see the tumor is completely has been removed, and the pituitary is there. So during this time of surgery, doing the surgery in brain tumors, what is our personal observation? We don't have problem on the clinical radiological diagnosis. We definitely get it comes to surgery and post-operative care, we have all the equipment at our disposal and the post-operative care. So we have the radio imaging, we can do this. The labs, we have them, it's not a problem. We have the ICU and HDU care post-operatively, and the patient can get medications on time. Although you see this is a yellow color because most of the things here probably they are not complete, especially the labs, you might not get them on time. So there was a small problem there, but surgery, because of the equipment which can assist us to perform the surgery in efficiently, some of them are lacking. That's why you see it's a yellow color. That's area for improvement. And also, after the surgery, that's not the end of the treatment. You see, after the surgery, you need to have a proper histopathological diagnosis. Not only a general diagnosis we are getting right now, but we need further analysis of these samples. We have to have the immunohistochemical markers for these tumors and the genetic molecular profiling of studies so that we can really focus our treatment or adjuvant treatment to the exact the pathology rather than giving umbrella treatment in patients whom probably they won't improve. And due to this inadequacy here, our patient overall free survival rate cannot be same as in UK. Also, if you see free disease survival as well as local disease control, there will be a little bit on the lesser side because we need to improve here and here. So, as I said before, we have a scarcity in human resource. At the moment in Tanzania we have 26 neurosurgeons, and half of these in Dar es Salaam, and a few are in the different regions. So you can see the number and distribution are not equal in the country. So we need to train more neurosurgeons to make sure that we have the country is well equipped in all regions. But also patient behavior. The patient usually they seek medical attention late when the disease has so much progressed. As the previous speaker who from the traditional medicine said, some of these patients they can go to consult traditional healers first before they resort to come to hospital. So there's a time lapse. Or when they are given the information in the regional or zonal hospital about their diagnosis, there is a denial phase. So in denial phase, they go back home, they take some time. So when they see there's a progress of symptoms, is when they decide that they are going to come to the hospital to get the proper treatment. So here also poor health-seeking behavior. There's a lack of comprehensive multidisciplinary approach in brain tumor management. And here we say there is a fragmented care. I will see the patient, I will operate the patient, and after operate, I will discharge this patient to go to Ocean Road Cancer Institute. So there is a fragmented information from my side as a neurosurgeon to the side of a oncologist, whether it's a medical or radiation oncologist, of what has been done here and what will be the progress. There is no mutual discussion between us and them in taking care of this patient. And due to this practice, the patient's their quality of life and the disease-free survival is not really achieved, the one which the desired one. So there is also limited operating equipment. We know that at Benjamin Mkapa they have a aspirator, tumor aspirator, the Cavitron, the Cusa, I can say, but it's only in one center and it's not in use. And the rest of the centers we don't have. So we have to struggle with these tumors. Some of these tumors are very difficult. You spend the whole day and the tumor is not out yet, so you can imagine. So this also brings down the efficiency of of these surgeries and their outcomes. Again, it's not possible. Again, on the molecular diagnostic resource, I think Muhimbili National Hospital Department of Histopathologists, they are doing this, but we don't have a really unit in that particular department which is focusing on the tumors from the brain and the spine. So we also get some difficulties getting diagnosis, and this is exemplified by the studies which was done, which was a photomicrograph, I can say it's a photomicrograph consultations with the, one of the histopathology department in Colorado, USA. And initially when they did this, and randomly they could find that the accuracy was about 36%. And after training, they picked some few people and they went, took them to training. And after training, the accuracy raised from 36 to 71%. So you can see, if we don't get a correct diagnosis, even if we send this patient for adjuvant treatment, the treatment probably won't be the correct one by the same percentage. So this is the situation which we need to correct and make sure that a multidisciplinary approach is applied to this type of patient. But not only this, I can say all the patients with cancers. Also, on the research aspect, we see, if you go to search on the publications, you can find some publications on brain tumors from Tanzania. Few of them, not so many. And these are just personal. There's no someone who is owning this research. There is no someone who is translating this research and taking them to another level, maybe creating policies and make sure that you make some implementations. So there is a disconnection. I can do my research for my own purpose so that people, they could recognize me on the world platforms. But does it help my country? Does it help those who are sick? So you can see there is a low yield of brain tumor research, but even the impact is also not what we expected. So these are the challenges which we see. So what are the way forward? The way forward is multidisciplinary approach, additional investment on surgical and diagnostic equipment, strengthening research component, strengthening local and international collaborations like the one we are starting right now, harmonization and unification of brain tumor data across the country. I think the previous speakers, most of them, they have spoken about this, I should not repeat. And when I say multidisciplinary approach, what I mean is you have a neurosurgeon, but this one cannot be very efficient if you don't have all other these units are working together with the neurosurgeons. So this is what I was saying. We have a neuroradiologist on board, people from anesthesia who are specialized in anesthesia on brain tumor surgeries, neuropathologists, oncologists, both radiational and the medical oncologists specialized on this field, neurointensivists and critical care nurses, neurologists, physiotherapists for rehabilitation. We need endocrinologists, pharmacologists, ORL, surgeons. All these are part and parcel of the team which requires to treat these patients. And so if we want to make this block here to look green, we have to do this. I won't repeat because everyone has spoken about this. Data collection, storage, analysis, interpret this data, and implement, formulate policy, and implement, then we are going to see changes here on this dot here. So this is not only just for brain, it's for most of clinical pathologies, including tumors on the wide aspect. So for neurosurgery, we are interested in the extent of tumor resections. So when we're talking about extent of tumor resection, we are talking about maximum safe resection aided by, I've spoken about this intraoperative neural monitoring, intraoperative navigation, aspirator as the equipment, microscope, but not only microscope just for seeing but a microscope can assist to do the with this indocyanate green or 5LA or fluorescein to really chase the tumor and remove all of the tumor, so it can increase the maximum resection area of the tumor. Also, safe post-op evaluation monitoring, and to have controlled CT scan. This is controlled CT scan, but we wish to have like hybrid theaters where we can do the, I can say, a real-time CT evaluation. You operate, you are not sure, you just push the patient to the CT and you push back to the surgery room and continue with surgery if you think there is residual tumor remaining behind. This makes an end of my presentation. I would just like to stress on the brain tumor surgery alone is not enough. We need to have adjuvant treatment afterward, and this depends much on histopathology. And this is immunohistochemical markers and molecular genetics studies. Again, thank you and welcome to Tanzania Tourist Destination. This is Arusha National Park. Be prepared to see this.
Thank you very much, Dr. Emery Chome, for your very good presentation. May I now call upon Dr. Mr. Parlock Jonathan, who is going to give us a talk on brain tumors and the MDT in the UK. He is coming. Jonathan Parlock is a consultant neurosurgeon based in Essex, Neurosciences Institute Center, Queen's Hospital, Romford, London. He is also a member of the Society of British Neurological Surgeons, the British Skull-Based Society, and also a member of the Congress of Neurological Surgeons of the United States. He has special interest in brain tumor surgery, particularly benign tumors of the brain and skull base, including angioma, hereditary adenoma, and acoustic neuroma. He has extensive general neurosurgery practice, including surgery of degenerative spine disease and peripheral nerve surgery. Dr. Parlock, the floor is yours. You're most welcome.
Thank you very much. Well, the good thing about this sort of joint presentation is it encourages you to be reflective, which is probably an oxymoron. You'd be surprised to find one reflective neurosurgeon, let alone two. So I'll do my best to match the standard of my colleague. Thanks to Dr. Mlama, we've had the opportunity to get working together already, in fact. As neurosurgeon, we've had two very productive Zoom meetings where we shared cases, and it's been extremely stimulating. So it's good to meet my colleagues and the rest of you face to face. I think as a result of that, what I'm going to do is pick up on some of the things that my colleague started talking about and focus a little bit more on the service aspects of what we do, because that's probably where we differ most. Talk to you a little bit about the regional service that we run from Queen's Hospital in London, a little bit particularly about multidisciplinary teams, which, as you've heard, are very important, and we're lucky because we're quite well supplied with multidisciplinary colleagues across the specialties. And from that, talk to you a bit about the subspecialty neuro-oncology that I deal with, along with my colleagues. Show you a few challenging cases, but not too many, for those who don't spend too much time dealing with these. And lastly, talk to you a little bit about the trends in neurosurgery that we're seeing and some of our own recent research. So Queen's is in East London. There are actually 7 neurosurgical units in London, 4 north of the Thames and 3 south. And we look after the patch of England which stretches out east from where we are, mostly into county what's called Essex, which is quite a large county by English standards and a very small one by Tanzanian standards. And we've been there a very long time, so we're one of the older of the UK units. Most neurosurgeons in the UK got going properly after the war. There were only a handful of units pre-war. And the story of how we started is quite interesting, so I will share it with you. The man in the photograph is a surgeon called Leslie Oliver, who trained with the first modern neurosurgeon in London, who was Hugh Cairns at the London Hospital, just up the road from us. And when war broke out, he was stationed out in Essex to look after the injured. And very early in the war, before the bombing had really started, a serviceman, unused to handling a revolver, was cleaning his revolver and shot his colleague through the head. And the bullet went in through his orbit and out through his frontal lobe. And Oliver was asked to repair the damage at Old Church. He did that with an eye surgeon who worked with him, who said, "You seem to be rather good at this. You wouldn't fancy coming back after the war and starting brain surgery, would you?" So he did, and so we've been there since 1945. Our region is very diverse in many ways, partly geographically diverse, so partly based in the countryside. So Essex has a long coastline, so we're partly coastal, partly very rural. This is supposedly the prettiest village in England, which is in Essex. And very largely the patch that we serve urban as well. So our patients come from wide geographical spread and also from very wide demographic and socioeconomic spread as well. And to serve them, although we have one neurosurgery unit, which is us in red, we have 3 oncology units, so 3 units that can deliver radiotherapy so the patient can get back closer to home, and that the long course of radiotherapy has a minimal impact on their lifestyle. One of those radiotherapists works in Colchester, one in Southend, and one with us in Romford. And between those 3 radiotherapy centres and 1 neurosurgery centre, we look at after 6 units. And most of our brain tumours come through the acute pathway, so they come when they are ill. They tend not to be diagnosed as incidental tumours, and that tells you not about the failure of the system, but about the central nervous system. It just takes a while for a brain tumour to be discovered. So a disproportionately large number of them come through the acute pathway. And one of the innovations we've had in the last few years is to accept those referrals through an online database, a thing called Refer a Patient. So when we're on call, we take referrals online for everything in neurosurgery, not just tumours, but also for subarachnoid hemorrhage and trauma. They all come through that system. We get about 30 to 40 referrals a day, which a small proportion will come for immediate urgent treatment. And in that subgroup, there'll be a group of brain tumours that we then either bring over immediately or work up and bring over once they're fully ready for treatment. And there are 7 of us treating brain tumours as cranial neurosurgeons in the unit. So to bring the team together, we have a weekly multidisciplinary meeting where we discuss the management of typically about 60 patients a week. And that takes us about 3.5 hours to work through the clinical history and the objective findings in each of those patients. We have a coordinator who puts that meeting together. We have the 4 clinical oncologists from across the region who are linked by Zoom. And between 2 and 6 neurosurgeons join each week, one of whom chairs that meeting. And we have a very experienced neuroradiologist. So grouped into that MDT meeting, as we call it, will be typically all the tumours that are accessed mainly by a neurosurgeon through some form of craniotomy. And by far the biggest subgroups will be meningioma, which happens to be a particular interest of mine, glioma, including malignant glioma, and metastasis, which we see quite a lot because there's a great deal of investigation of cancer patients going on in the National Health Service. So we see a large burden of NETs. They don't all come to neurosurgery, but we do see a lot of them. And to add to that, so to take out the subsets of tumours that need a different skill set, we have 2 other MDTs. So we have a skull-based MDT every week, which is run by 2 neurosurgeons, myself and a colleague with an interest in skull-based tumours, and a completely different group of specialists. So we bring into that at least 2 of our 4 ENT surgeons, 2 of whom have an interest in lateral skull-based approaches, putresectomy, and so on, and 2 of whom are rhinologists. We have a maxillofacial surgeon, and Chelmsford unit, you saw in the middle of the region, has a very large plastic surgery unit with a couple of plastic surgeons who are interested in head and neck cancer, and with quite a large burden of squamous cell carcinoma. They see a reasonably sizable subset of tumours that start outside the head and find their way inside, so they're done jointly by plastics and neurosurgery. And just to finish off all of these subsets, we have another MDT that we do fortnightly, specifically for pituitaries. And this is where Gideon and his colleagues come in. So this is where the endocrinologist comes to the fore, because most of the patient workup is endocrine. and that will either be treating pituitary adenoma, or some of the tumours with a slightly larger burden of endocrine care. Craniopharyngioma is very much endocrine management very much dominates with those. Two of us as neurosurgeons who treat them, and very important attendance from radiotherapy because they have quite a large radiotherapy burden. So that's how those cases are sort of managed week to week. And in terms of case numbers, we see a large number of glioma patients. We see quite a high number of meningioma patients and a lot of metastases. We also see a lot of skull-based tumours, but many of those are incidental. So some of those come through a completely different pathway. Many of them will be asymptomatic. As many of you know, pituitary adenoma is present in up to a quarter of the population. So with ENT surgeons scanning thousands of patients a week, we pick up quite a lot of those as incidental findings, and they go down a rather more leisurely workup. But some of them will present with visual failure. Our inpatient facilities for dealing with them, we've got 12 ITU beds. We also make use of the neighbouring HDU to deal with the immediate post-op patients who need a little bit more attention but don't need ventilation. We've got 45 inpatient beds, and as of the last few months we've now got 3 lists running each day. 2 of them are elective, and we have 1 emergency list on which we put acute hemorrhage and tumours that need urgent theatre, and quite a lot of spinal fixation goes on those lists as well. So in terms of the adjuvant bits of equipment my colleague was alluding to, we have our fair share of those. We're lucky enough to have a very recently installed piece of image guidance equipment called BrainLab, which in essence, for those of you who haven't seen it at work, is a piece of sat-nav that takes you exactly to where you want to go. And the version that we have now will also produce a sort of 3D image or impression of the tumour, which projects into the microscope view that you get. So it gives you a very accurate idea of where you are within the tumour volume, or at least where you are within the tumour volume as it was when the patient was scanned. And as you remove the tumour, to bring that into real time, you can add ultrasound, and you can merge these 2 sets of images, so you can see exactly how much of the tumour you've got left with ultrasound. My colleague alluded to intraop CT. We just acquired an O-arm, mainly to keep the spinal surgeons happy, because it tells you where to put your screws, but it does also double up as intraoperative CT imaging of the brain. And just to give you a brief overview of some of the approaches, this is an unusual but nevertheless an intrinsic tumour, so a tumour in the middle of the brain. This happens to be a meningioma, but it gives you a flavour of some of the things that we discussed when we look at these tumours. Those of you who can remember your neurology might remember that getting straight to this tumour through this part of the parietal lobe would not be great for your patient's speech. And this is exactly the sort of case where we spend a bit of time discussing the best approach to get there. And this, in fact, was a tumour that we treated through superior parietal lobule to avoid the maximum impact on the speech area and on the visual cortex. And that's the tract that we used to take it out using image guidance. So that was an intraoperative meningioma. Intraventricular meningioma, it's like an unusual location to find one. And another one that came up for quite a bit of discussion about how to access it. This is a recurrent hemangioblastoma. These are extremely vascular tumours of the cerebellum, which give you a very interesting day out if you aren't prepared for them, because they lose blood at a quite alarming rate. And this had been approached some elsewhere underneath the tentorium, and at that point a lot of bleeding was discovered, so the tumour was only partly resected, and then came to us after some further growth a little bit later on. And on that occasion we went underneath the occipital lobe and through the tentorium to get to it, which gave us a rather better exposure of the tumour and enabled us to take it all out. So these are sort of examples of cases where it's worth investing a little bit of time in team discussion of how to manage them. And some of the skull-based tumours are also accessed through a craniotomy alone, so you don't necessarily need an ENT surgeon to do some of these. This is a rather unusual, rapidly growing meningioma in a very young patient that was nevertheless accessible through a craniotomy without needing a multidisciplinary surgical approach. And just to bring together some of those skills, I thought I'd show you a rather interesting patient who, where we've had several ways of several sort of discussions about her over quite a long period of time. So this patient was 52 when she presented, and she's just had her operation at 62, just to give you an idea of how sometimes we don't always charge in at the first opportunity. This was a patient who presented with falls, imbalance, and with unilateral hearing impairment, and turned out to have a rather spectacular meningioma of the posterior fossa. And if there are any medical students sitting around, you remember how many pairs of cranial nerves there are in the head? 12. 12, dead right. And unfortunately for the neurosurgeon, 9 of them are in the posterior fossa. And in this particular case, 15 of those 18 cranial nerves are either directly involved with capsular tube or actually encased in it. So that's not a great surgical project, which is the reason why we didn't operate on her when she was 52. Because in fact only one of those nerves had a deficit when she originally presented, and that was her right-sided 8th nerve. All the rest were perfectly intact. And that would be a challenge to tackle at that stage. So we had a long, careful think in several MDTs about what to do with that. And in fact, there's quite a wide range of what you could do. In an older patient, you might just discharge them. These are very benign tumours, so you may well get away without needing to treat that at all if you were confronted with it in an 80-year-old. But at 52, that wasn't very likely to happen. And we therefore took her through a pathway that included a period of monitoring. We treated her hydrocephalus, which made her feel a lot better, and in fact improved her walking significantly. And we then watched it for quite a long time. And luckily for her and for us, nothing very much happened to begin with. So after the first 2 years, the tumour looks very, very similar. Her walking's better. Her hearing is no better but no worse. And then over a period of time, as you might expect in a fairly young patient like this, what began to happen is as the tumour is getting larger, it's starting to make life more difficult for any future surgeon to tackle. So it's encasing the basilar artery at this stage, which is a bit of a bad sign because encased vessels give you a much more difficult day out if you're going to operate on them. So at that point we thought it was time to start discussing surgery, and we just operated on this with what's known as a pre-sigmoid approach, which my neurosurgical colleagues will recognise as coming from a very talented American guy called Mefti, which involves taking out the petrous bone and then operating just immediately medial to the space that you create by doing the petrosectomy. So our ENT colleagues carried out the petrosectomy, and we've taken out a substantial portion of it. That's a pre-sigmoid approach, of which we now collected a few. So that's at the sort of more complex end of the scale. That was one of the earlier of our petropliable meningiomas treated the same way. And this young lady presented at 23, she's still under our care at 35. She's had 2 operations since that time, utilising that approach. So very briefly on where we're heading, as opposed to where we've been so far. Things are getting more minimally invasive in terms of approach. I'll just briefly show you some new classifications that we've touched on earlier. So a little bit of risk stratification, and show you some of our recent papers. But suffice to say that the trend in neurosurgery is towards smaller and smaller craniotomy. So you can imagine that, given that all 3 of these craniotomies were done for a similar sized brain tumour, you can see that you're likely to get away with a much shorter hospital stay, with less pain, and indeed less complication with a smaller craniotomy. So that's very much a trend of where we've been heading in the last decade or 2. Part of that is increasing use of the endoscope. Hesham Kadur is my ENT colleague who's led on this and does a very beautiful approach to the cellar region for us with endoscopy. That's a pituitary adenoma done through the nose, and this is a meningioma treated through the nose. The downside to this approach is you don't know how to repair the access that you made, but that's perfectly doable. That's one of his endoscopics. In terms of classification, we're getting much more information from the pathologists than we ever had before. And just to show you one example of that, with meningioma, these were previously classified almost completely morphologically by what they look like down the microscope. What we've been able to add to that in the last few years is much more information to predict why some of them behave in a rather surprising way. So whilst most of these tumours grow very little at all, you find the occasional patient where there's very rapid growth, and you can't explain that on the basis of traditional histology, but you can when you start to add in some of the molecular subclasses of meningioma, and in particular when you combine the information you get from all this molecular information to provide an integrated risk score. So when you've operated on one of these, you get a very strong clue from this additional data about how it's going to behave in the future. That partly tells you how long you have to follow the patient up, and it also is very helpful at telling you whether you need to give radiotherapy. And that question of giving radiotherapy, I'll come on to that fairly swiftly, is gradually being resolved now by the Rome trial, which was set up by a colleague of mine in Liverpool, Michael Jenkinson. We enrolled in this trial, and the aim of it was to compare patients who were radiated with those who were observed and see how the two fare. We're going to get the answer to that in 2025, so we'll then know where we are with irradiation of meningioma. Lastly, just a few of our recent papers. We had a nice, pleasant intellectual distraction recently by discovering when we came to write up Mr. Oliver and his patient who was shot in 1940. We started to look at neurosurgeon Colby Sutherland and found that it goes back rather a long way. In fact, the first English paper on brain surgery was written at Barts in the 1780s. So that gives a little distraction from our normal clinical research. We've also looked at hydrocephalus in our schwannoma patients quite recently, and in amongst various case reports that we pick up from the skull base group of patients, we also wrote up that suboccipital transcensoral route, which has proved quite useful over the last few years. And I thought, lastly, inspired by our journey in the airport, I'd just point out that the use of crash helmets in motorcycle riders was written up by an East London neurosurgeon a long time ago, in 1941. And this was Hugh Cairns, who was presented with large numbers of dispatch riders during the war, and discovered that, surprise, surprise, they were doing very badly from head injury. And it would be a sensible idea to put a crash helmet on them. So it's funny how these things come around and turn out to be useful much later on. Thank you very much.
Thank you, Mr. Park. I would like to call upon all the presenters for the session to come in front for a quick session. Kathleen, Joseph, Erasto, Dr. Lemeni, we'll take 3 questions, then they respond, and then we'll proceed. Anyone with a question? Yeah.
Good afternoon, everybody. My name is God Balvame. I'm an ENT surgeon and neurologist. So my question goes to the last presenter, Mr. Pollock. I'm interested in both vestibulology. The patient that you talked about with the posterior fossa tumor, were there any ocular findings like nystagmus or anything? Thank you.
Thank you. Continue to collect questions. Can you take 3 first before we respond? Or you want to respond, Mr. Barlow?
Probably a good idea to deal with that one because it's very specific. The answer is interestingly no, and one of the intriguing things as those of us that see these patients notice is quite how resilient the brain is, not just in the posterior fossa but throughout the head, in tolerating tumours which get bigger very, very slowly. And it's interesting that with those post-fossa meningiomas, not at all unusual for it to be only hearing that's affected, and that was the case with her. That was the only deficit she had for those first 10 years.
Thank you. Another question?
My name is Dr. Yuri Saka, I'm a radiologist from the National Hospital of Brazil. My question goes to Dr. Lemeni and Dr. Pollock. From the presentation of Dr. Lemeni, you said it is shown that meningioma, the first, has the highest incidence or highest prevalence in Tanzania, followed by gliomas. while the presentation from Dr. Polo showed that gliomas were the leading, followed by meningioma. So I was wondering, this makes this twist up of the presentation between meningioma and gliomas between Tanzania and UK. I mean, do we have different risk factors, or what is happening to give us this kind of a picture? And my second will be, because we have a representative here, I think it's a time now we have a brain tumors registry, because the data which was presented here was from the two centers, which probably is not representative of the whole of Tanzania. So maybe it's time to have a brain tumors registry, so we can have a wide picture of what is happening in Tanzania in case of brain tumors. Thank you.
Thank you. Thank you very much. Can we take one more before we respond? Only one?
Yes, if I may ask a question. Hello, Manpreet, EM consultant. My questions are directed at Dr. Mwanga and Dr. Mshome, Dr. Sylvanus. Really fascinating books about the development of the trauma registry and data collection. As you're aware, we have a trauma audit and research network in the UK that's been established since the 1990s. I was wondering what particular data will you be collecting, how would you use that data to develop your trauma network in Tanzania? Thank you.
Thank you. Starting with Dr. Lenere, who has, I think, 2 questions to respond, please.
Thank you. The question is why the differences in pathological results in Tanzania and the UK. In Tanzania, we have our studies or observations shows higher incidence of meningioma compared to the UK, where it's glioma. For sure, I will not say what is the reason, because this is just an observation. This is what we saw when we are analyzing this data. But if you go through the previous literature worldwide, you will see that meningioma is the leading type of pathology in the intracranial tumors. I'm not sure about the UK, it depends. If you take maybe subgroup analysis, you might find probably glioma is more prevalent in certain age group. I'm not so much sure. Maybe I'll take this back to Mr. Pallock to add on it.
Yeah, I think it's a really very interesting point, and it's actually a very striking instance of the sort of interesting data that you turn up when the two groups sit next to each other. I'd be very surprised if it's a true difference in incidence, or at least I'd be very surprised if that's a predominant reason for it. I think it's very likely that it's more to do with the fact that we're both neurosurgeons, so we're not giving you population data. What we're giving you is the subset of those patients that present to us. And I suspect the reason they're so different might have quite a lot to do with access to scanning, because one other subgroup that you didn't mention in the question, which was noticeably different between us, was the instant metastases. So we see a lot of brain metastases because we have a lot of patients who get imaged with cancer, some of them with absent symptoms. So some of them, for example, get isotope scanning and mets are picked up that way, even though they're asymptomatic. And I suspect the same applies to the glioma population, that because of the high availability instance of scanning in the UK, we're picking up a lot of low-grade glioma that probably would go undetected if our access to scanning was less prevalent. I think that might have something to do with it.
Thank you. You have another question for somebody?
I think maybe the next question was directed to Minister of Health about tumor registry.
But yeah.
Yeah, thank you very much. That's a good question. There is a form, the WHO trauma form, that was adopted. There were some additional information that were put to include other things like poisoning, snake bites, animal bites. Those were only added things, but mainly it was the demographics of patients and the profile of the demographics, the injury information, all the detailed description, falls, specifics go on, like drop down options, and then as usual, the care that was provided, the initial care, the findings, so they are put there. Like point of care, ultrasound findings, you drop down, you put the information of the assessment, the head-to-toe assessment, those findings are put down. And then the outcome is also put after the disposition of the patient, whether I went to surgery or went to normal ward or whatever, is put of that data. So it is a detailed information. It's just that it is put in a way that when you have a patient of trauma, there is a certain way of putting data together. But it actually would have been just other way of documenting the patients. So this was just to make sure that we have some specific information uniform across the country so that we can run the data and make comparison and analysis afterwards. Yeah.
Thank you. Thank you very much, Dr. Silvanus. Because of time, can we take one more question, then we break for, we continue in the next session, please? So,
thank you very much. Very great presentation from all the participants. I wanted to direct my name is Dr. Sharma. I'm a clinical pathologist from Uganda. I wanted to direct my question to Dr. Jonathan Pollock and maybe also Dr. Leonard Nchome. And my question is about the role of brain tumor biorepositories or biobanking in terms of brain tumors research, but also brain tumor treatment services. So what has been the role of this biorepository? I think I've seen in literature, quite many in Europe and other places where there are well-established biorepositories or brain tumors biobanking. So what is their role in research and also in brain services, brain tumor services? Thank you.
before you respond, that one last question, please. One last question for the session.
Thank you very much. I am Dr. Baraka, an intensivist. Thank you all presenters for a very good presentation. This question goes to Dr. Erasto and some from the Ministry of Health. We had a presentation about the hard landing. We have seen how motorcycle accidents affect the life of young people. The thing is, one day we can be the victims. We just do vestibular reconstruction, amputation, etc. But maybe one day this will happen to our wives or children or brothers and fathers. So, Dr. Erasto, you being at the Ministry of Health, you being an emergency physician, how do you use your influence to the policymakers about these motorcyclists? Do we still need borders to be a means of transport? We as experts, what do we advise the government? Because it's just a matter of giving a technical advice to the policymakers, and this can be reversed, and we can save thousands and thousands of lives of young people.
Respond to the first question, then.
Shall I just comment on the tissue banking issue? And it's very, very topical. So thanks for raising it. There's a strand of brain tumour research, for those of you not familiar with it, which, to summarise it, only works if you use fresh frozen tumour specimens. And that is taking us into areas of brain tumour therapy which are not yet proven, but which are experimental, notably use of vaccines in brain tumour treatment. And And our response to that at Queen's is we just started freezing brain tumour tissue as of the last year so that we're able to provide tissue for patients who want to go down that route. But at the moment, we rely on guidelines that come from an organisation in the UK called the National Institute of Clinical Excellence, and that the guidance that we're actually provided with about how to treat our patients is sort of out with that type of research. So that's a little bit, it's a bit ahead of where we are at the moment. But to respond to it, we just started freezing our tissue at Queen's.
Yeah, talking about the role of brain tumor biobanking, I think I have no different opinion as Mr. Powell has just said. We normally use this for study, knowing the pattern of the disease and the other characteristics, so that we develop management protocols for the different type of tumors. I don't think if there is any other additional information we get from this, apart from improving treatment of our patients.
Thank you, Dr. Baraka, for question about policy, but to rescue our colleagues and ourselves, because we use such transport. It is true that it is really a big burden to our hospitals and to ourselves. Colleagues are also being disabled out of these injuries. Efforts have been made. We understand it is a challenge. We had, through this year's and colleagues, and we invited all the police teams, the organization for drivers, motorcyclists, all the stakeholders. We had a meeting about this, and it was presented. This 60 to 80% of all the injuries we face in the hospitals are for motorcycles. So it was very clear, and they understood it. And there were some comments that were put together so that everyone would play their part. And most of the big chunk of it was on the law enforcement. And our colleagues assured us that they tried to start with the utii wa sheria bila shuruti. They thought that because most of our brothers in motorcycling business are people with low, I don't know, we call them wanakipato kidogo. Sasa when they are very strict with those laws, they cannot operate and they complain. So they want to start with another model of educating the team. Instead of using force like our colleagues in neighboring countries, put very strict measures, and well, the accidents have gone down. But for us, we have chosen a different way of doing education, and then they will start enforcing the law. Now, the PRH has also took that into consideration. They want to register all the motorcyclists in their points of service. And for them to stay there, they need to have a registration, they need to have more helmets, and they have a leader that will be responsible to allow anyone to ride in that center without these gears that are protected. And that is also what we want to do in our ministry. We use the preventive services, screening of other diseases, etc., to accommodate some of the causes of motor traffic crashes. Yes.
Yeah, I think we also need to learn from other countries. Like the Southeastern Asia, countries like the Indonesia, if you go to Vietnam, Cambodia, countries like Indonesia, we may learn from those guys. They used to have a very high burden of motorcycle crashes, but they had to infiltrate from the primary level of education on safety measures, how to cross the road, how to take care of injured patients, how to avoid and prevent these injuries. I think from that level, we can build our nation. But now sometimes these old guys let us make noise, continue to pinch them, but it may take longer time. So let us learn from other countries on how they manage it.
Thank you very much, and I'm happy that I don't have any questions because I think the hard truth of what my colleagues presented hits us very well. I have a little bit of contribution of what is the problem with our young men with border motorcycles. I think we need to do a better job than that. You know, if we enforce right now, we're not actually revealing the root cause of the problem. The problem is these young people have no jobs. They're not employed. When you have a motorbike which is not yours, there's actually how it works. You have to give the owner a certain minimum amount of money every day. So the whole reason they rush is because they have to maximize the time of the day and night so they can actually have something extra as an income. So one of the things is we need to talk to them deeply, and we have to find ways for them to get, if there could be a subsidy for their income using the motorbikes, maybe that will be a reason. But I think as long as they don't have jobs, this is going on. If I ask you, any one of you right now, when you're driving or when you're being driven, just look at the way people are not obeying the traffic laws. And that will tell you something. There's something in air. There's something in people's side that is making them drive recklessly. We've done all these mobilizations, we've done the training, we've done everything, but just look how they're driving. And that will tell you there's something brewing underneath. And I think we cannot wait until they all die or they all become disabled. Thank you.
Yeah, just one, if you can allow me, Mr. Chairman. There are many, I can say, platforms which have spoken about this, and they have thought about stopping the border from operating. But if you look the percentage of young population unemployed who have self-employed in border, to push them away from the employment is not possible. The moment you push them away from border, you are creating another crisis. So this is inevitable. They have to continue. But when they were looking at what could be possible solutions, they saw that probably the most important thing is behavioral change. So now most of the institution, from the training institution, from the authority which gives the license, and from the authority which enforce the law, traffic laws, all of them, they are targeting changing behavior. So in every step, they have this proper training on behavior and how to operate these borders. Because they believe if we change their behavior, the accident rate will go very low or almost to zero. Thank you.
Thank you very much to all the presenters. It was a very good session. We take the mic back to the MC. Thank you.
Thank you. Thank you very much to the presenting team for the very elaborate and very informative session. There's a lot of burning questions which I think we should continue later on in the roundtable discussion at the end of the last module. Thank you very much. Therefore, we left. To the moderators, Dr. Anthony Asay and Dr. Harry Humba. Thank you very much. We are 30 minutes behind schedule, so to account for this, we're going to go straight into the final session. But whoever needs to stretch, go to the washroom, grab a cup of tea, please feel free to do so in an orderly manner. I would like to welcome Dr. Kisenge and Dr. Mandi to lead us through the final session. Thank you very much. This session is going to focus mostly on acute coronary syndromes in both Tanzania and UK, as well as endocrine and diabetic emergencies in these two countries. Thank you.
Thank you very much. Dr. Mali is coming. So can you just stand up and do like this? Can you stand? Everybody should stand, please. Can you do like this? Okay, you can sit down. So, first presenter is Dr. Kuzema. Dr. Kuzema is an intervention cardiologist, and he is also head of training at the Cardiac Institute. He's done a lot of intervention at the cardiac both diagnostic and the complex procedure. Recently started doing the TAVI procedure at the Cardiac Institute. Dr. Kuzema is also developing cardiac work for training at the Cardiac Institute together with the University of Dar es Salaam. He's coordinates all the training at the Cardiac Institute. So without much ado, please, Dr. Kuzema, welcome. Let's see, I would like to, if my co-chair introduce yourself.
I'm Mandy. I'm an IT consultant from Queens in Oxford. And I'm also a local research lead with the NIHR. And yeah.
Good afternoon. I think we are going to evening now. I think this is the marathon we started in the morning. It's in this final stage, the final 5 kilometers. So I hope you have the strength to finish this marathon on top, right? First of all, thank you, the organizers, the UK Tanzania Symposium, the Ministry of Health was organized this symposium. And I think since morning, I think what we have brainstormed more is research, and research. Without local data, we don't move ahead. And I think the importance of local data is what everyone has learned from this symposium. That with collaboration, we need to have a local data to improve the outcome of our patients. It's not about individual, it's about collaboration to improve the outcomes of our patients in Tanzania. And so I'll take you to the acute coronary syndrome pathways in Tanzania. I'll talk about more of the STEMIs, which are the debilitating diseases and which is more time bound than even having said that I don't have time, I just have 90 minutes. So we all know cardiovascular disease is the most common cause of mortality and morbidity worldwide, and a substantial portion of this burden is borne by low and middle income countries. In sub-Saharan Africa, the incidence of acute coronary syndrome is presumed to be increasing amid the rising prevalence of risk factors such as hypertension, obesity, and diabetes. In Tanzania, example, coronary syndrome is currently estimated to be fourth leading cause of death in the country. This was published by the World Health Organization. But despite such estimates, ACS remains a rare diagnosis across sub-Saharan Africa, a fact that has perplexed epidemiologists. Now, if I say the spectrum of acute coronary syndrome, it starts from abnormal ECG when the patient arrives, clinical context, and then to see if the patient is stable or not stable. It has got the whole syndrome, but to see the whole chart, you should only have 90 minutes to treat this patient. And it all starts here. When a patient arrives with a chest pain at an emergency center, the first thing is to diagnose acute coronary syndrome. When you diagnose acute coronary syndrome, is there where you time what is the total ischemic time from the time the patient has chest pain to the time the myocardial will die, and to intervene you only have 90 minutes. And if you don't reperfuse within 90 minutes, the outcome is debilitating in terms of long-term management and treatment of this patient, which is a burden to any country and any health sector, because long-term management of a cardiomyopathy is lifelong medications for these patients. So this is what we are fighting for, and this is what we at JKCI are trying to fill the gaps with the help of Ministry of Health. And a big round of applause for my director who started the chest pain unit last year for recognizing this thing, that this is important chest pain unit for time to muscle. So with the help of my executive director, Dr. Kisengi, we managed to have a chest pain center. And what we are advocating now is to how to get this patient to get a timely management to the patient with acute coronary syndrome. Now we have a local registry in Jakarta, Kikwete Cardiac Institute, and we have just collaborated with Gati, American College of Cardiology. And in this last 6 months, we've got total 69 STEMI cases, which are only STEMI, and 54 were direct referrals, 46% were thrombolized and then transferred. Those who were transferred more were from Northern Zone, Arusha, Moshi, and other areas, and then from Zanzibar, the island we're going to visit. Average referral time and transit time was always more than 12 hours to this patient. But when they reach to our cath lab area, they go within 90 minutes with their children to take them to the cath lab. We have got 6 cath labs in Tanzania total, but we have got 5 in Dar es Salaam, 2 are at JKCI, and 3 are private, and 1 government owned in Dodoma. And a study which was done last year, this was done by us at JKCI, which showed that the average referral time, if you see, most of the patients arrived at the center more than 12 hours. And those who were majority arrived at 24 to 48 hours, and there were also patients who arrived at more than 48 hours. But those who were locally, most were referred from phone call, but those who come from our country were referred from letters or by referral note. So what we did, we started first STEMI conference in 2023, where we invited all the emergency center doctors and everyone, all medical who are dealing with emergencies, to the first STEMI conference which was done in Tanzania, Dar es Salaam. And we advocated how to treat a STEMI patient. The patient will come with chest pain, and to advocate guidelines. And we say time is muscle. So what are the strategies to move forward? We created a STEMI WhatsApp group. That was the fastest way to get all the doctors on the group. We have now over 1,000 doctors, and they are linked to this JKCI STEMI group. So anyone who has an ECG with chest pain, they put up on that group. And we are always online from JKCI, or any other doctor who is online who could read that ECG will give an immediate diagnosis. And then what we do is a train forward model. So we train them how to approach to this ECG and whatever availability you have in your settings to treat this patient immediately before the patient can be transferred for an invasive therapy. So what we are advocating is thrombolysis, because you see we only have 6 cath labs across the country who are dealing with acute coronary care syndrome, and from there we need thrombolysis because this is the first kind of a treatment for patients to save the muscle, and then do a facilitated transport to a nearby center where they can do a percutaneous intervention. So we have a registry with GATU. We also register partnered with Ministry of Health, Tanzania Cardiac Society, and JKCI, a state stable life initiative, where I think is still in the final stages of implementation, and hopefully soon we'll implement that as well. We did a survey which showed that what is the availability of thrombolysis around the country, and we found out that only 22% of the public facilities have access to these drugs, and 47% to the private facilities. So what we are looking for is a collaboration to implement thrombolysis with Ministry of Health and other collaborators, so that every facility in the country has a chest pain unit, has an ECG machine to identify the acute coronary syndrome, and to advocate thrombolysis before being transferred to any nearby cath lab facility where they can get an invasive strategy. And we can shorten the time for referral, and we can shorten the time for muscle damage. So what are the areas of potential collaboration? One is capacity building, which we think that cardiovascular imaging is a field which is missing. Critical care and coronary care units, where adult and pediatric team are focused on this. Cardiovascular nursing, interventional cardiology training fellowships in adult and pediatric. Hopefully we will soon start an interventional cardiology program at JKCI, which is in the final stage. Minimal invasive cardiothoracic and vascular surgery fellowships. Research have been talked about since morning, and extension of services such as chest pain unit with collaboration with Ministry of Health and JKCI. JKCI would like to take over this with Ministry of Health if they allow us. So go through every part of the country and establish a chest pain unit, as a JKCI chest pain unit, and do a telecardiology consultation. So, question to the floor: what do you see here? Who can answer for this? Yes, timber. Yeah, Kirani Histo. You see, the one who will stand on the podium is the driver, but behind him is the whole team who makes him to reach the podium. So this is the team, I think, is where our patient is the car who needs to reach the podium. To save the patient, we all need to team work together and to build this way forward model and to give the best clinical care to our patients. With that, I welcome you all to our third Cardio Tanzania conference to Zanzibar next year, which will happen in April 10 to 12, and which are all, again, our team is strengthening cardiovascular care in Africa through collaboration. So we are there at JKCI for collaboration. We welcome you all for collaboration, and our teams have been collaboration because we want to have the ground health of the Tanzanian people with collaboration from every country to improve the health of Tanzanians. With that, thank you very much. Time is not up. Let's collaborate to save the world.
So, next presenter of the, yes, okay.
Thank you, very grateful. So next presenter is Professor Andrew Diener, who's a consultant cardiologist at BHRUT and Bart's NHS Trust. He's an honorary clinical professor in the Centre of Cardiovascular Medicine and Devices within the William Harvey Research Institute, Queen Mary University of London. Professor Diener qualified at Leeds University in 1987. His postgraduate training was in Yorkshire and then East London. He was appointed as a consultant cardiologist at King George's Hospital under London Chest Hospitals in 1996. Although always primarily a general cardiologist, his initial subspecialty interest was in echocardiography. He moved across to coronary intervention with the advent of primary PCI. His other significant clinical interests is in maternal cardiology, having set up the cardio-obstetrics service in North East London soon after taking up his consultant post. He was appointed Site Medical Director at King George's Hospital in 2022. Previously, he held senior educational roles in health education in England, London, including a 5-year role as head of School of Medicine. He has an enthusiasm for global health and has visited Myanmar, Nepal, East Africa with a view to developing health partnerships. So, Professor Diener, over to you.
Just sorting the slides out, so whilst
any question to Dr. Kuzena? You're allowed to ask him any questions. Any questions to Dr. Kuzena?
So thank you very much, Dr. Kuzema, for your presentation. We know the way what DKSI is doing. But I want to ask you about the chest pain clinic or chest pain center. So anyone with chest pain, can they self-present to your clinic without being referred?
Yes, so our chest pain is 24/7, and we are doctors on call. And anyone who has a chest pain can come directly to KCI saying I have a chest pain. We will start the ECG machine. The doctor will do an ECG and see if the chest pain is related to cardiac. If it's not cardiac, and you see the patient is still in chest pain and you are not cardiac cause, then they are reported to the national hospital or the center. But yes, they can enter any time of the day. And just inform our nurse that I have a chest pain, then the nurse will take the patient to the chest pain doctor or the doctor or any doctor in the clinic in the morning hours as well. Our clinic runs from early morning. Our director starts at 5 o'clock in the morning. We start at 5 a.m. and our clinic runs to 8 p.m. in the evening. So yes, that's
And how many patients do you see in 24 hours?
Our average see clinic, our outpatient clinic caters for 450 to 500 patients a day. 450 to 500 patients a day in a day. We have got about 6 consultation rooms, 2 for surgeries and 5 for cardiology. And over the day we see about 450 to 500 patients a day.
apologies. So, whilst we just download the slides, I'll start. So, it's a great privilege to be here today, and we've been working on this for about 18 months, haven't we, Gideon? So, we're really pleased that it's come to fruition. I'm going to talk today about acute coronary syndrome in the UK, and things are really very different there, of course, because myocardial infarction, coronary artery disease is incredibly common. About 50% of our population die from cardiovascular disease, and many of those from coronary artery disease. We have a high incidence of hypercholesterolemia, we have a high incidence of diabetes and fortunately a reducing number of patients who smoke. But nonetheless, we still have a high prevalence of coronary disease, although it is getting less, and I'll show you in a moment that our mortality is reducing. Brilliant. So, sorry for the technical delay. So, just to recap, so coronary artery disease gradually will appear, and we know from post-mortem studies of GIs during the Korean War, so back in the 50s, that even 19, 20-year-olds would have early atherosclerosis. But it's only later on, when the vessel becomes significantly narrowed, that patients develop symptoms. And as you can see, gradually the lumen through which the blood flows will narrow, and that will produce stable symptoms. But at some point, it's possible that the endothelium will ulcerate and thrombus will form. And suddenly, the flow of blood through the vessel will reduce and lead to either a myocardial infarct, if there's a complete occlusion, or to a non-ST elevation infarct, where flow of blood still can get through a degree of what we would have previously called unstable angina. And the important thing to remember is that there are two parts to treating an acute coronary syndrome. Firstly, a mechanical intervention may be necessary to improve the flow of blood acutely, but very importantly, there are pharmacological approaches that are really important to reduce the thrombosis that's occurring. So this cascade of platelet activation, fibrin-rich clot forming and blocking the vessel, and as well as opening up the vessel, we need to give the appropriate drugs to stop this from happening and stop it from recurring. And then finally, we need to look after the patient, help them rehabilitate, and provide them with drugs that will reduce the risk of recurrence, so secondary prevention. And this is something that we've become very good at because we deal with so many patients who present in this way. As I said, the incidence and the mortality of coronary vascular disease is gradually reducing. That's partly to do with improved diet, as a result of improved social economics, but also the reduction in smoking, and we've got better at dealing with hypercholesterolemia. However, the numbers that we deal with in the UK remain very high indeed. So the numbers at the top of this slide show that in total, in the year 2022 to 23, we dealt with nearly 90,000 patients with an acute coronary syndrome. The majority of those have non-ST elevation infarction, but there's still a very significant number, nearly 30,000 who have ST elevation myocardial infarcts. And as our previous speaker enforced, time equals muscle. So the sooner you can get blood flow back to the myocardium, then the less damage is done to the myocardium. And as I explain to my patients over and over again, the most important thing is the amount of damage done to your left ventricle. If your left ventricle, after whatever happens to you, is working well, then your long-term prognosis is good. And we're really quite good at secondary prevention, so if we've looked after you properly, we've prevented significant LV damage, then you're likely to have a good outlook. So I qualified in 1987. Shortly after I qualified, ISIS-2 was published. And ISIS-2, for those who don't remember, was the seminal paper produced by colleagues in Oxford that showed that thrombolysis in combination with aspirin reduced mortality significantly. I then lived through the whole period of thrombolysis, then combined thrombolysis followed by PCI, maybe a few hours later or maybe further afterwards. But then in the late 1990s and then particularly in the mid-2000s, 2000s, we moved to primary angioplasty. We're very fortunate in the UK. We have the resource. We're a very densely populated island, so patients are always pretty close to a hospital. And we've been able to move pretty much 100% to primary PCI as our treatment. So it's very rare now for a patient in the UK to be given thrombolysis rather than come and have a primary PCI. And to try and reduce mortality, we still need to reduce the time between the patient presenting with Erivol or developing symptoms of myocardial infarct and receiving revascularization therapy, so primary angioplasty. And our target is for a call to door time of 90 minutes and a door to balloon time of 60 minutes. And we vary in how well we deal with that target. And you can see that in recent times we're doing less well, and gradually our times for both door to balloon and call to door times have gone up. And we need to work very hard to reduce these. And you can see the combined effect of those. I'm going to talk about what we do in our part of North London. We're in North East London. We have a series of heart attack centres in the UK. And in London we have these heart attack centres. Since this slide was made, the London Chest Hospital, where I worked for 20 years, and the Heart Hospital have combined, and we're all on a new site at St Bartholomew's Hospital. It's a beautiful new hospital. We're really fortunate to have it. It took a long time to come about. And you can see here the hospital is quite an old building. It's Regency. It's a Regency building, and it has a lovely quadrangle, a lovely place for patients and staff to sit at lunchtime. And our ambulances come to us directly. And I'll show you the pathways in a moment. An ambulance in the UK is quite a complex vehicle. I'm sure your new ambulance fleet is very similar, but it's full of very advanced equipment that can keep a patient going for a long time. And we're fortunate that we've had paramedics available to us and looking after our patients for many years now. Once the ambulance arrives, so the ambulance will arrive at the person's home, they will assess the patient, they will do an ECG, and they're all trained to recognize ST elevation myocardial infarct, and some arrhythmias and left bundle branch block, and assess the patient. And if they feel that based on the ECG and their assessment this is a myocardial infarct, they come directly to the heart attack centre. And that's quite important because Barts is a standalone cardiac unit with a bit of respiratory and a few other specialties, but doesn't have its own ED. So patients are brought directly to Barts on the basis of what the paramedic decides. They don't phone ahead, they don't get any advice, we rely on them, they're really skilled and experienced operatives. When they get to us, the patient is generally brought up to a receiving room, that's the bottom right. We have echo there, we have further ECGs, and we can do it with an anaesthetic machine and so forth. And the patient is assessed by an experienced registrar and often by the consultant. So when I was on call for AMIs, which I was until I became the hospital director or medical director of the hospital, I would stay in for 24 hours, stay in overnight, so you were available immediately. A decision is made whether the patient should go to the lab, and if they need to go to the lab, they go straight through to the lab, which is 5-10 yards away from the receiving room. And we take them in and we do an angiogram and hopefully are able to provide the appropriate treatment. So just going through our algorithms. So patient has chest pain, most will call 999, but sometimes they will drive themselves to hospital because they haven't recognized it's a heart attack. Theoretically within about 8 to 10 minutes, an ambulance should arrive, they assess the patient, and if it's an ST elevation infarct, they can take them straight to the heart attack centre as I described. Once they're assessed, they may either go to the cath lab, or if there's a reason not to go to the cath lab, they need stabilising, for instance, or it's felt that it was a misdiagnosis, they go to the ward and are assessed further, and may go to the cath lab at a later time. If they go straight to the local emergency department, they'll be assessed as soon as they arrive, they'll be triaged, an ECG will be done, and if it's felt that they should have gone to the heart attack centre, then they will be moved immediately to the heart attack centre. But that delays things a little. Many of our partner heart attack centres are on the same site as emergency departments, so they may take patients from their own emergency department. But only a small proportion of the overall number of hospitals in the UK have a heart attack centre attached to them. Many of our patients who don't have ST elevation infarct who come to the to the DGH, so to us, will then be admitted, assessed. If they don't have ST elevation but have high troponin, or they feel that they require angiography, they'll sit on the ward and wait, and then be transferred, usually as a day case, to the cath lab at the heart attack centre, have their procedure, and then come back the same day and go home the next morning. Other patients who we don't feel having infarcts will be treated appropriately. So there are a few patients who've had out-of-hospital cardiac arrests, and you hear about these. We will make a decision, often in discussion with paramedics, whether the patient should come to us or not. So we may get called to have a discussion, or the paramedics may bring them directly to us. A good example would be a patient that I'm going to show you in a moment who has got ROSC, so recovery of spontaneous circulation, or restoration of spontaneous circulation, who has ST elevation on their ECG, and then they'll be treated just as a straightforward STEMI patient would. Others who are very unstable, and it's not clear whether it was myocardial infarct that led to their arrest, will be taken to the local hospital, stabilised, either moved almost immediately to the heart attack centre, or stabilised on ITU, and when they're appropriate to move, and they'll be moved to the heart attack centre for investigation. 80% of our patients who have angiography now have an approach from the radial artery to reduce their complications significantly, and pretty much 100% of them will be stented, and almost 100% will be stented with drug-eluting stents. We've stopped using bare metal stents. Just very quickly, a very straightforward case. This was a patient in the gym, developed chest pain, had a cardiac arrest. Unfortunately, there were people around who learned CPR and were able to start resuscitation. There was a defib available, and they were defibrillated and came back around. So they've got ROSC, and you can see that there's clear-cut posterior infarct. Come to the lab. So they're brought to the heart attack centre, go straight to the lab, got a blocked circumflex artery, ballooned and stented, and you've got good flow return. That's our bread and butter cases. Those who are as old as me will remember that myocardial infarcts used to be called coronary thrombosis, and for good reason. So occasionally nowadays, although we went through a period where we did this on every patient, we would do thrombectomy, pass a wide bore tube into the coronary and literally suck the clot out of the artery before we carry out stenting. And you can see that this is a case that I did. You can see the little worm of clot that's been taken out of the coronary artery. So that just there to remind you the importance of the anti-platelet and anticoagulants that we use. We give everyone aspirin. The ambulance will load them with 600 milligrams of aspirin on the way. They will load them with clopidogrel 600 milligrams, although at a later stage we may swap them to ticagrelor or prasugrel. We use ticagrelor, other units use prasugrel. Whilst we're doing the procedure, we give them heparin. We frequently monitor their anticoagulation with an ACT, and if necessary, we'll give them even stronger antiplatelet drugs, a 2B3A inhibitor, such as integralin. The use of dual antiplatelet therapies has completely changed the way we work. When I first started, we were using stents. There was a high incidence of acute stent thrombosis. We tried all sorts of different approaches. We had big problems with hematomas. But once a drug called ticlopidine, very similar to clopidogrel, came out, the whole situation was changed. How do I do it? It's just on my screen, sorry. So once a patient's been admitted, started on antiplatelet drugs, we then, of course, are going to see them on the ward round. We go through some important points. So we check their ECGs, we examine them, make sure they've got no evidence of other underlying pathology, such as dissection. We review their LV function with echocardiography, and this allows us to decide when we're going to send them home. If the LV function is preserved, we send them home very fast, and I'll just show you some evidence supporting that. We give them dual antiplatelet therapies, but if they need oral anticoagulation as well, so it's commonly because they're in atrial fibrillation that we have to make an individualized assessment of what combination to use and for how long, particularly if they're elderly and have a high bleeding risk. And we also have to make decisions about anticoagulation in patients who may need early surgery for some other pathology. It's really important we explain to the patients what's happened to them. plan the next steps. So one of the things that we found was that a lot of patients who do very well would stay in for 3 to 5 days. We were being pushed on the number of beds because the NHS is often under a lot of pressure, and we chose to look at whether we could send patients home at an earlier time. And when I started doing cardiology, everyone stayed in for at least a week. We reduced that to 3 to 5 days, and then colleagues came up with an approach where you picked up the low-risk patients and we arranged for them to go home, sometimes after just 24 hours, often within 48 hours. And at first I thought, this is crazy, why are we taking this risk? But you'll see the evidence is strong, this is safe. So we're basically picking out the patients who are suitable for early discharge because of their level of risk. And many, as I said, will go home in less than 48 hours. This is run by a combination of an advanced clinical practitioner, usually a senior nurse working with our pharmacists. Along with making a decision to send them home early, we provide them with a lot of support. So you can see that they're contacted by telephone within 48 hours by a clinician. We then make frequent contact with them. They have some apps on their phone to allow them to report patient-recognised outcome measures. We give them support in terms of rehabilitation, talk to them about diet, and we're available to support them if they have recurrent symptoms at an early stage. And patients really find this very satisfactory. So these are the inclusion criteria for early discharge. So good left ventricular function, a successful procedure, absence of any other lesions that need to be treated during the same admission, no recurrent chest pain, and no significant arrhythmias. And they need to be mobile and have appropriate social circumstances to go home at an early stage. And between April 2020 and March 2023, we sent home 1,500 patients through this pathway. And you can see here that they did extremely well. There were 9 deaths in subsequent 12 months, which is just 0.13% cardiovascular mortality, with a very low major adverse cardiac event rate and a low major adverse cardiac and cerebrovascular event rate that compares very well with a comparable group of patients treated in the traditional way. So this has saved us a huge amount of time for our patients. Now, the second group of patients deal with non-ST elevation infarcts. This is a very typical one, South Asian woman, middle-aged, presents with chest pain, has a normal ECG but a moderate rise in her troponin. She's given standard treatment in DGH and then moved across to the heart attack. Then she's got a tight mid-right coronary stenosis, stented, ballooned, and we get a lovely result. Second bit about bread and butter. These patients tend to do very well, but often because of the pressure on the service sit for rather longer than we would like. The target is for over 90% of them to be dealt with within 72 hours, and the reality is most units are only managing to deal with about 55% of them in this time. So we looked at a way of trying to take out the low-risk non-ST elevation myocardial infarct patients and move them quickly out of hospital and deal with them as outpatients. And there's strong evidence to suggest that you can pick out the patients that are low risk and they do well. So we have inclusion criteria where we pick them out using Gray score, which is a measure of coronary risk and mortality risk. They have to have been pain-free for 48 hours, have relatively minor ECG changes, small rise in their troponin up to about 150. They need to be stable. No evidence of left ventricular failure, so we do an echo before they go and check their LV is more or less normal. They're sent home on appropriate medical therapy, and they get a date to come back the next week to have their angiogram. We give them an app for their smartphone, and they need to log in on a daily basis to say they're feeling fine, and if they're not, they'll be brought back in as a matter of urgency. And with using this pathway, we have a group of very satisfied patients. We've saved already 1,760 bed days, which is very significant within the NHS, and we've saved a lot of money. And so far, we've had no significant major adverse cardiac events in this group. We've done 185, so out of the 430 patients that have gone through this process, we've done 185 PCIs. Many have been treated with medical therapy. These are low-risk patients, and some turn out to have relatively mild disease or no disease at all. And a small group have had to be treated with coronary artery bypass grafting. So in summary, we take a full system approach. We're helped by targets such as door to balloon times. We have to make an initial appropriate assessment so we get the patients in the right place. We bring them directly to the heart attack centre as often as possible when this is appropriate. They get early revascularization. We know that that reduces mortality. Remember, this is a combined revascularization mechanical approach plus the pharmaceutical interventions. It's important that we use appropriate dual antiplatelet therapy and anticoagulants. And remember, these are dangerous combinations, so you want to use the right combination, and you need to balance the risk of the drugs against the benefit. And we've taken the opportunity to use innovative pathways to benefit our patients and improve efficiency, as I've shown you. And don't forget, it's really important to make sure these patients get cardiac rehabilitation and their secondary preventative drugs. I always show this at the end of a talk about chest pain because we've got to the point where we manage many of our patients according to a menu, to pathways and guidelines, and not all patients fit in with those. And it's become quite common that patients, their troponins find their ECG looks all right, they can't have anything seriously wrong, but there are other causes and other life-threatening causes of chest pain, such as pulmonary emboli or an aortic dissection. Thank you.
So, thank you very much.
Next speaker is Dr. Faraglia. Dr. Faraglia is Assistant Director at Medicine in Europe. She's also a endocrinologist. So Dr. Faraglia.
Thank you very much, everyone, and thank you all who have managed to stay until this time. I know it's late in the evening. Although the topic is endocrine emergencies, but it will be nothing like Dr. Mwanga's hard landing that we've had with his motorcycle accidents. So, as I've been introduced, my name is Dr. Faraglia Chiwanga. I work as an endocrinologist at MNH. So I've put up this first slide just to show, for the sake of today's presentation, we are going to discuss about diabetes ketoacidosis. In the perspective of Tanzania, I'll only be touching on the issues that we have in managing DKA, and then Professor Mnao will take over on actual management as of standard of care. I've put the rest just to show when people ask and I say I'm an endocrinologist, sometimes the follow-on question is, what exactly do you do? What is your work? What conditions do you treat? It's easy to say I'm a diabetologist, everybody will understand, but endocrinology is very difficult. So in terms of emergencies, we do have other issues of thyroid and adrenal issues as well. But the most common one by far is diabetes, and it's both hyperglycemic complications in terms of DKA and osmolar hyperglycemic state, as well as hypoglycemia. So when we talk of diabetes ketoacidosis and hyperosmolar hyperglycemic states, these are common acute complications, and they represent an extreme in the spectrum of hyperglycemia. Now, in low and middle-income countries, including Tanzania, we may find DKA is the first presentation of diabetes, and this is most of the time because of delayed diagnosis or missed diagnosis. This is the published by one of our colleagues, Dr. Majaliwa, way back in 2007, and it showed almost 90% of the children and young adults who are managing diabetes were presenting at some point with DKA. Now, at this point, is to note that there were a lot of efforts in terms of partnerships with non-government organizations and international partners, and we were able to have a lot of programs, especially for children and young adults, and the numbers decreased. But as you can see, it's almost like we've reached a bar. The second one, the amber card or the orange, was in 2020, where you see, and this is the most recent one. This is 2022, this is 2020. The numbers are still the same of children and young adults who are presenting with DKA. So the risk factors are several, and just to talk about this, I've not projected the mortality rate is also very high, and depending on how we manage them. Now, the risk factors for DKA in Tanzania, as I mentioned before, most of the time is because patients will have diabetes, but they are not yet diagnosed. So the fact that they have high blood sugar and they are not diagnosed, the first time they will come to the hospital with already very high blood glucose level in DKA. But also, even for those who are diagnosed, there are issues of poor glycemic control. The most recent study that was done in children, average HbA1c, which is a marker of our glycemic control, is 11%. And it's not unusual for us to have A1Cs of 14% for those tests that can read up to those levels as well. And we have inconsistent insulin supply. As I mentioned before, most of the time we rely, especially for children who need insulin for survival, we are very much depending on programs. So these are donor-depending programs. So sometimes if the funds are not enough at that time, or the project period has ended, you find you have a shortage of supply. But apart from that, we have issues with glucose monitoring devices. We are still relying on glucose meters, but even with that, they are expensive. Again, if they are not able to go to the facilities to get them in terms of programs, it's not possible for them to be managed. And this, when I was listening to Caroline in the morning, it was a little bit depressing to me when she was talking about 70% being managed at primary care facilities. You'll find these patients, when they go to higher level facilities, yes, they will have those, they'll have insulin, they'll have glucose meters and things like that. But they cannot keep on going back to the same higher level facilities. At the end of the day, they need continuity of care at the primary care level. And this is where you find the supply is not consistent there, and they end up not getting the supplies they need. Now, they need to raise funds so that they can travel to a nearby facility, which is expensive for the families. And then, of course, we always have an issue of infection. In terms of management, now the first thing with DKA is first to identify its DKA. To identify its DKA is also difficult, especially when you have, I don't know if we have pediatricians, a lot of pediatricians here, but when you have things that we call syndromic approach to the management of childhood illnesses, that when you have fever, when you have abdominal pain, when you have, and then there are conditions that are written there. Now you won't have that will say, think of DKA. But the presentation, especially for children, are very non-specific, and even for adults. They are very non-specific. They will complain of abdominal pain, they will complain of this, they will complain of these symptoms that are not specific. To have that index of suspicion that it could also be DKA is very difficult. And then coupled with the fact that sometimes you are dealing with a child who is not even known to have diabetes. I remember things have improved quite a lot, but I remember way back when I was doing my what we call community rotations in one of the district hospitals here. The only glucometer that was available in that hospital was the medical officer in charge's personal glucometer. And then that same week when I was there, it was stolen. so the hospital had no glucometer. It was very difficult for us to manage. And then the worst case scenario, there was a lady who came unconscious, non-diabetes, unconscious, was on insulin, was adult patient, diabetes, on insulin, and then she came unconscious. And then we were stuck. We don't know whether it is hypoglycemia or it is hyperglycemia. So the doctor decided to give glucose because that is probably the wisest thing to do. And then eventually we realized it was hyperglycemia, and it was a scandal. The whole district, the doctor doesn't know how to treat the patient with diabetes, was given, I think, dextrose or something. So these are the challenges that we are having, especially in the facilities where we are supposed to manage 70%. So whenever we are talking about programs, whenever we are talking about collaborations, as much as, for example, in my case, as much as I think about my tertiary center, but we cannot forget to also think about the lower health facilities. Otherwise, I will do a very good job at Loganzilla, for example, where we have the largest diabetes clinic. But then when they go back, if I also, when I discuss partnerships, if I also don't factor in where I'm going to send back my patients, this is also going to be a problem, because all the good work we'll do at a tertiary center, at the end of the day, they are not going to be coupled by sustainability as well. And then we have to think about guidelines. What do we talk about when we talk of guidelines? Here we have to think about adaptability. We'll learn how we manage by standard of care, but I think we had a lot of discussion in the morning. Yes, about where do we manage our patients? Do we manage them in ICU or do we manage them in the neuro wards? Our ICUs, you heard in the morning when Baraka was presenting about the number of beds. I think those who went to Loganzilla yesterday, you heard the emergency medicine doctor saying that, oh, sometimes we stay with a diabetic DKA patient until it's resolved at EMD because they don't know where else to send the patients, where they can be properly or saved and managed. So this is usually the dilemma. And now I have a luxury of saying that because I'm working at MNH. So I can talk of emergency medicine, I can talk of ICU, I can talk, but there are so many other places where 70% of our patients are attending that do not have that luxury. So it's how do we adapt to make sure that we manage DKA in that context. Insulin, we know we need to use IV insulin, but again, how do we do that? When I was a medical student at KCMC, one of the things that we like to do was to count drops using IV lines, because that was something that we can do in the absence of infusion pumps. That was something we like to do. But then we realized when we do that with insulin, and then you've written there in the bottle that this one should run up to 2 p.m. Maybe at 1:30, the nurse will pass, or anyone, and see the bottle is still 3/4, and this one should end at 2 p.m. And then it will be open full, until the fluid, because that's the time that you need to change. So we realized that was not a good practice, and we changed. But you change to what? If you are saying that you want to do an IV insulin. So we settle for subcutaneous, sometimes 4 hourly, 6 hourly. It's not standard of care, but it helps. So it is how we also need to know how to adapt. Whenever we are talking of innovations, it's not only about technology, but it's also how do you innovate within your limitations, especially where we have limitations of resources, the choice of fluids, but also monitoring where we do not have access to electrolytes, for example, and things like that. So we have developed guidelines, local Tanzanian guidelines for management of these conditions. At primary care, what we really wish is for them to identify, at least be able to identify that this is a problem, and then start fluid, and we are saying they should start normosaline. But the question is, do they have normosaline? Maybe there's no normosaline available. So do you say give any fluid that you have, then they will be given probably dextrose is the one that is available, especially because of maternal health. So these are the things. But as we've heard all the way since morning, that there's a lot of improvement in terms of infrastructure. It's just now how to adapt these guidelines and very simple messages to primary care facilities that they are able to just sustain these patients until they reach a level where they can manage. But again, the other challenge here will be how do they actually reach that next level? That's where we have which is probably going to help, but depends on the locations as well. Now, this is what we advocate. They can have subcutaneous insulin or IM even, and then transfer them to higher center. At the higher level, that's where we think they're going to get a comprehensive management, including management of the underlying conditions, as well as management of complications, if they will end into complications. So I just wanted also to bring to your attention about endocrinology services in Tanzania. As the same as my colleagues from the intensive care unit, is still very young. We are very few, at least in the pediatric side. There are quite a number of them, I think around 20 to 30 now. For the adult endocrinologists, not so much. We are still looking for each other. We are scattered. We are not very well organized like other specializations. And of course, most of us are concentrated in tertiary level facilities. But there has been a lot of efforts, especially with what we call National NCD program, where training, especially last year and this year, training has gone up to health centers, I think this is, health centers, on at least the identification of diabetes being able to diagnose. But when we talk about other conditions, there's still no clear pathway. For example, with thyroid conditions, we don't know who has to manage them. Is it an endocrinologist? Is it a surgeon? So you find, oh no, these ones are not for example, if you go to people who are registering patients, they say, if you have a thyroid problem, you have to go to a surgeon. And then there are others who are being managed at Ocean Road with nuclear medicine physicians. So it is not very clear who has to manage what conditions. It's the same as pituitary tumors. Alvin knows. Sometimes I tell, have you ever discharged a patient with a pituitary adenoma without even calling me? So yeah, I think Dr. Lemeri alluded to this earlier, that our multidisciplinary teams, we have seen, and we are very happy for these partnerships, because even with the presentations, we already see where we need to strengthen how we do it, especially how we organize ourselves in terms of multidisciplinary teams. So you find some of the things, they don't even need financial resources, just ideas, and this is what friends are for. Just to get ideas is also a positive thing. The diagnostic tests, as I've already said, and the multidisciplinary teams. So what is the next steps? What we want is, again, I'm not going to repeat this because it has been topics of almost all the presentations. We need to have information. I was once in a discussion about whether we should continue using some of the sulfonylureas, and there was adamant saying, well, because they are cheap. So I was in the position, in the side of saying we should continue using them. And then I got a question is, but do you know how many patients are harmed by sulfonylurea? Do you know the mortality if you compare between people who are using sulfonylureas and people who are not? And I could not say that. I have 4,000 patients registered in my clinic, but I cannot even say what is the lifespan of my patients, what medication that are better than others. So this is what we've been talking, the use of routinely collected information in our hospitals, and most of our tertiary hospitals have an electronic health record system, but still we cannot feed to the ministry because we cannot use it to analyze and come up with recommendations that are based on evidence. Training of healthcare workers, I said we are few, but sometimes it's because the causes themselves are not available in country. So if we are able to establish both short and long-term causes within the country, this will also help us. And then I know with the partnerships, these are the things that we can also develop together, both in terms of short training, but also even the long training in terms of masters or masters of science. And then, as I said before, we've been talking about multidisciplinary teams, very impressive from our partners from the UK, and we think this is something, this is a low-hanging fruit that we can actually take from here. Thank you very much.
Brilliant, thank you. Next we have Professor Gideon Malawa. So Professor Gideon Malawa qualified in Traki University, Bulgaria. He pursued further postgraduate training with both Wessex and London deaneries in the UK, specialising in endocrinology and diabetes general internal medicine. He's currently working as a consultant physician in diabetes and endocrinology general internal medicine at Queen's Hospital, Romford, London. He is a director of medical education at both Queen's Hospital and King George's Hospital. He is a training programme director for internal medicine trainees, Royal College of Physicians tutor, Royal College of Physicians of Edinburgh regional advisor for Greater London. He's a founding member of Tanzania's UK Healthcare Diaspora Association TAHEDA and a treasurer. He's actively involved in global health collaborative and partnership schemes within East Africa. He believes in medical education as an ongoing journey and not a destination. Prof, over to you.
Thank you. Thank you very much for inviting me today. And I think Dr. Faraja has talked about managing endocrine emergencies in Tanzania. I know Dr. Faraja for the past at least 5 years. I visited Tanzania, and when I visited Muhimbili before I met her, and we talked about being able to collaborate. So I'm going to try and talk about diabetes emergencies. When we talk about diabetes emergencies, we talk about DK, which I'll talk through it, but I'll talk through the case report, one of the cases I've seen in London, but also other forms of diabetes emergencies that are the so-called hyposmolar hyperglycemic state, or HHS, as well as hypoglycemia. But in acute setting, most of the patients we turn to see, we're going to see patients who have got hyperglycemia without DK or HHS, and in this case, sometimes it's a new presentation. It can be classed as the acute hyperglycemia, and therefore one has to make a diagnosis if the patient is just a new patient who is not known to have diabetes. In the UK, we've got over 4 million people living with diabetes, and about 1.2 million, they are living with diabetes, but they are yet to be diagnosed. And almost 80% of that, they are type 1 diabetes. That's about 350,000 patients. And the cost of treating diabetes in the UK is about 10 billion. And most of it is on medication, recurrent admissions, and therefore it's a serious condition, not only in the UK, but in most global north countries, and also as well as low resource setting countries. So let me share this case of a patient I saw before. It's a patient who is 40 years old. She's non-diabetic for the past almost 30 years. And therefore, she was diagnosed when she was 10 years old. And if you look at her, she comes with lower back pain and the urinary symptoms. And previously, she was admitted, or she comes with the kind of UTIs and previous admission to DKA, as well as hypercholesterolemia. So it's a patient, sign of the kind UTI and DKA, possibly maybe she had a poor control, and I'll try to touch on the role of technology in managing this patient or supporting patients with both type 1 and type 2 diabetes, but also the role of technology in trying to prevent recurrent admissions, whether with acute hyperglycemia or DKA. So this is the regime of patients. She's taking a basal bolus regime. She's taking long-acting insulin, in this case Lantus, but also she's taking short-acting insulin, which is novorapid. She's also on statin, for that matter. And when she comes, she's hypotensive, she's tachycardic, she's tachypneic, but she's got normal saturation room air. The tachypnea, somebody would say it as shortness of breath, but actually, if she's not diabetes, you worry about if she's in DK, can this be Kussmaul breathing? And these are some of the investigations when she's in. She's got high white cell count and also high CRP, and therefore there's element of infection. She's got AKI ureas of more than 10, and also creatinine is slightly high. But look at blood ketones, it's more than 7. And she's got severe hyperglycemia because of 41, and HbA1c is 90 millimoles per mole, implying that her control is very poor. So in summary, it's a case of 40 years old lady who is non-type 1 diabetes for the past 30 years. She comes with being generally well with fevers. She's hypertensive and tachycardic, and she's in AKI, but also looking at the blood test, we're getting very high blood ketones, but also hyperglycemia. The question is this patient has got DKA? That's the question. So this slide just tells us what's a normal blood ketone. So if a patient, most of our type 1 diabetes patients in the UK, they've got ketone meters. So when they are unwell, they will call our diabetes nurse. They might call our diabetes. I'm not well today. My ketone level is 0.4. So that will be reassuring. If they say that my ketones level reads high, means more than 3, they're at risk of getting DKA. We advise them to come to hospital so that we do blood gas to try and define DKA or diagnose DKA. So the type of ketones we tend to test, there's acetoacetate, then there's beta-hydroxybutyrate, and acetone, which is more rare of ketones. But if you look at when we do blood ketones, it's mostly beta-hydroxybutyrate, and therefore doing blood ketones is the best practice. When I was training as a junior doctor, we are taught to make sure that if the patient is on a sliding scale or an insulin infusion, you continue sliding scale until there's no ketones in the urine. But that was a wrong approach because there's always a lag between blood ketones and urine ketones. So the best practice is to use blood ketones, and therefore all our type 1 diabetes patients in the UK, they've got blood ketones. So going back to our 40-year-old lady, that's her blood gas when she came, and obviously she was in research. She got severe acidosis, pH of less than 7, look at bicarbonate of less than 5, and base excess of minus 29. But also she's got hyperglycemia and high lactate. So given the fact that she's got fevers, she got and that's a trigger, and she's acidotic, a pH of less than 7, and therefore we talk about what are the indications for admission to ITU. So one of the indications for admission to ITU is severe acidosis, a pH of less than 7. If you've got bicarbonate of less than 5, which has got 1.5, but if they've got low GCS, if they're hypotensive, and if they've got other comorbidities and they're desaturating, you have to make sure that, yes, initially these patients, they will be in resource, but their pathway will be going towards HDU unless they improve. So for this patient, of course, she was given insulin infusion in the form of fixed rate, and the way we give fixed rate insulin infusion is per kilogram. So 0.1 units per kilogram. If she's a 60 kilogram individual, she will need 6 units of insulin while she's in DKA until she improves. Go back to my patient. She's non-type 1 diabetes. She's taking long-acting insulin, which is Lantus. So we tend to give long-acting insulin alongside the insulin infusion to make sure that they get a quicker recovery to prevent rebound hyperglycemia or rebound ketosis when you stop the sliding scale. So for my patient, because she was septic, in this case it was urosepsis, we gave her IV tazocine, and she was admitted to ICU as a part of pathway. So yes, we are talking about a 40-year-old lady who is type 1 diabetes. She comes with DKA. In this case, the trigger is infection, which is a common cause of a trigger for DKA, almost 30%. So she stayed in ITU, and that is one of our infusion in terms of giving and dosing insulin per weight for our patient, which is within the hospital guidelines. So going back to our patient, that patient stayed in ITU or ICU for 24 hours, and actually I came to see the patient when the DKA had resolved. And the ITU or ICU team called me that, can you come and see this patient who came with DKA over the weekend, and now she needs to be stepped down because her DKA is resolved. So how do we define DKA? So the definition of DKA, if you're British, by British criteria, is hyperglycemia, glucose more than 11, acidosis, pH of less than 7.3. If you've got blood ketones in the blood or urine, but also you can add the bicarbonate of less than 15. So by definition, if Mrs. Smith is 40 years old, comes with glucose level of 11.5 or 12, think about DKA by this definition. But if you look at Americans, they define their DKA in a different way, and for them, it's the hyperglycemia, glucose more than 13.9, acidosis, pH of less than 7.3, if they got bicarbonate of less than 18, but also ketones in the urine or blood. I think the take-home message for this is not what criteria you use. The take-home message is, if somebody comes to your unit and maybe they've got hyperglycemia, ask yourself, can this patient have DKA? And therefore, you want to define the DKA. You ask to do blood gas to look if they are acidotic or not. You ask for either urine ketones or blood ketones to make sure that they've got to get the triad of hyperglycemia, acidosis, and ketosis. And maybe you add the bicarbonate. And one's going to ask, why should the Americans use different criteria as compared to British? But if you look at most guidelines for DKA or HHS, is based on consensus statement. If I say Dr. Faraja works in Mloganzila Hospital for the past 10 years, based on her population, she might tell me that her patient, when they come with DKA, they've got a sugar level of 14.5. So it's just based on that. But the most important take-home message is, if somebody is hyperglycemic, ask yourself, can this be DKA? And don't miss the DKA. You make sure that you do the diagnosis by doing blood gas to make sure that they're not acidotic. You want to check ketones and make sure that they've got no ketones either in urine or blood. But the best practice is to use blood ketones for that matter. And this slide just summarizes what I've just told you in terms of trying to define DKA. That is acidosis, pH of less than 7, hyperglycemia. If you're British, glucose more than 11. If you're American, more than 13.9. But also if you've got ketones in the urine or blood. But you can add the bicarbonate of less than 15 if you're British, or less than 18 if you're American. So sometimes we tend to get patients presenting for the first time in hospital, and the question is, can this patient coming with hyperglycemia, can this be DKA or HHS? So DKA is almost always in type 1 diabetes patients who are non-type 1, but also we are increasing getting a lot of patients now with advance in treatment. We are getting the new medication, we've got a new medication, the so-called SGLT2 inhibitors, and these medications can cause the so-called euglycemic DKA. And therefore, we are getting type 2 diabetes patients who are taking the SGLT2 inhibitors for diabetes or for cardiovascular prevention. They can present with DKA for that matter. But in terms of differentiating between DKA and HHS, if you look at the pH in DKA is less than 7.3, but in HHS it will be more than 7.3 unless they've got a combined pathologies. So some patients will come with sepsis. They might be acidotic because they're septic, but some of the patients are non-CKD, or they come with acute kidney injury, and therefore they can be acidotic for that reason. If you're not sure, and therefore you have to treat this patient at least as type 1. So this is a simplified version of trying to explain the pathophysiology of DKA. In most patients who are non-DKA, we know that they've got almost no insulin at all, or relative insulin insufficiency, and with that, you get the high levels of the so-called counter-regulatory hormones, namely glucagon, cortisol, adrenaline, and that can cause increased hepatic glucose production, causing severe hyperglycemia, and for these patients to be very dehydrated. But the body needs, or the cells needs, alternative source of energy, and therefore you get lipolysis, formation of free fatty acid, and the formation of ketones, and the metabolic acidosis. So I talked about what are the triggers of which triggers DKA. Almost 30% is due to infection, but some patients who are coming, they can come with a new diagnosis, 10%, and some of the patients who are non-diabetic already, they've got poor compliance. They don't take their medication, and therefore they can present with DKA. And other conditions which can cause stress, such as myocardial infarction, patients presenting with stroke, they can present for the first time with stroke as well as MI and DKA. The explanation for that is the fact that in these patients with MI or stroke, it's a stressful situation, and if you check their stress hormones, i.e. the so-called counter-regulatory hormones, they will be very high. They will have high adrenaline level, high cortisol, and high glucagon, as well as growth hormone, and therefore they can cause hyperglycemia and trigger the so-called DKA. In terms of clinical features of presentation will be different based on the time of presentation. Most patients who are very health conscious and very aware of their condition, they might present to hospital very, very early, and therefore they might come with just a high glucose level, but they might be having high ketones but not acidotic. In this case, you can define as they are having pre-DKA. But those who are sometimes they are very unwell, is simply because they come to hospital very late, and therefore they can come with vomiting. Sometimes they can present with severe abdominal pain. I just want to make a point that DKA should be a differential diagnosis of acute abdomen. In the old days, some of the patients would present with acute abdomen and they undergo laparotomy, but they find that maybe they don't have appendicitis, but they've got DKA. So we have got pathway within the hospital in terms of managing patients with DKA, the first 1 hour to 6 hours, the first 6 hours to 12 hours, and the first 24 hours. So most patients, ideally within 24 hours, their DKA will resolve unless they've got other comorbidities. If you are managing them properly, they will get better within few hours to 24 hours. So if you get a patient with DKA, of course, you're going to manage the patient like any other patient by using A to E approach. You have to assess them and make sure that you stabilize them. And when we try and assess these patients, initially we want to try and define DKA by, you've got a glucose level, they've got hyperglycemia, they've got maybe ketones in the urine or blood, but you want to know the blood gas. So one is going to ask, am I going to be doing this patient, taking blood from them by doing arterial blood gas or venous blood gas? Arterial blood gas is very painful, and therefore the guideline is you can do the first initial blood gas as arterial blood gas, but the subsequent blood gas should be venous. And the evidence is the difference between arterial and venous blood gas is just minimal, it's about 0.15. And if you look in terms of bicarbonate, the difference between venous and arterial bicarbonate is just about 2. Why am I talking about this? I'm talking about this because when you are managing this patient, we talk about the so-called metabolic targets. When you are managing them, you'll be doing blood glucose every 1 hour, but also you'll be doing blood gas every 2 hours. And what are you looking at that? You look at to make sure that the blood ketones are going down by 0.5 millimoles per hour, the glucose level is going down by 3 millimoles per hour, but also the bicarbonate is going up by 3 millimoles per hour. So that is why we say that initially you can use arterial blood gas, but the venous blood gas will guide us in terms of managing these patients who are actually very unwell the first few hours of admission. And the fluid of choice, we use normal saline. And if you look at this patient, the initial fluid resuscitation is very aggressive unless they are known to have heart failure, and therefore you have to modify their fluid regime. And that's a main stem of treating this patient. Of course, you're going to treat the trigger in terms of sepsis, but also fluid resuscitation is the most important part of treatment of DKA. And when you are doing that, you have to make sure that you look at the electrolyte imbalance, i.e. potassium. So if they are non-diabetic, they are taking long-acting insulin, you continue long-acting insulin, and also, as I've said, we use fixed-rate insulin initially, and the explanation for that is previously we used to use sliding scale, it used to work, but if you take there is a change in phase of type 1 diabetes. If you look at type 1 diabetes in America, he might be 150 kilograms. And with that, if you give them using sliding scale, you might not be giving them enough amount of insulin, and therefore that makes them to stay only sliding the cell for longer, and you invite complication, and you prolong the length of stay, and that's not necessary for the patient. But also we give long-acting insulin for the same explanation that if they are taking long-acting insulin, you want to prevent rebound hyperglycemia or rebound ketosis. So these are some of the charts we use when the patient comes initially for fluid, is on hospital guidelines. And also we used to have paper form before, but now everything is more on intranet. But trying to manage these patients, everybody is involved. We still talk about the role of MDT. So our diabetes team is not made by one person. We've got a diabetes nurse, we've got a nutritional team, we call dietitians, but also in some patients who have got mental health problems, it's not uncommon to get patients with chronic condition and having mental health problems. We involve psychologists, we involve psychiatrists. But in this setting, a diabetes specialist nurse, dietitian, and diabetes doctors, they're trying to support these patients who come with DKA. So the question comes, when you are seeing the patient, when do you give them potassium when they're coming in acute setting? So this slide just summarizes, it tells us that when the patient comes with DKA, if you look at my patient, she had a potassium of 6.5. So initially we will not give her potassium because you got a potassium more than 5.5. You have to try, and if it's less than 5.5, yes, you can add potassium on some of their fluids while you are monitoring them every 2 hours. So this slide just says the same in terms of when to give potassium and when not to give potassium. And we keep monitoring this patient and involve the diabetes team early, and we use normal saline most of the time, but when the glucose level goes below 14, we use 10% dextrose as a part of managing this patient until they come out of DKA. So I talked about the so-called metabolic targets. When you're trying to monitor these patients, managing them the first few hours, you are looking to make sure that their ketones level are going down by 0.5 millimoles per hour, their glucose level is going down by 3 millimoles per hour, but bicarbonate is going up by 3 millimoles per hour, and you maintain normal electrolytes, in this case, potassium. I just touched previously about what are the indications for admission to ITU. We said that if the patient comes with severe acidosis, pH of less than 7, like my patient, if they're hypotensive, if they've got low GCS, if they're desaturating, and sometimes you get a lot of patients who have got a lot of comorbidities, and therefore they go to ITU not because of DKA, they go because they've got other comorbidities. If you get a patient who is known type 1 diabetes, they are known to have CKD, they are known to have heart failure, it's bad news, and therefore you can't manage them in a normal ward, and therefore it's better for them to go to HDU or ICU for that matter. And when do you stop insulin infusion? Of course, or sliding scale, is when the patient acidosis resolves, they're out of DKA, and the ketones are less than 0.6. But most importantly, you have to make sure that your patients are eating and drinking. So I wanted to touch about the role of technology. For my patient, if you look at the past medical history, she was coming with recurrent UTI, but also recurrent admission with DKA. So we've got a privilege in the UK to have access to technology. And one of them is continuous glucose monitoring, the so-called Freestyle Libra. So for this patient, I gave her the Freestyle Libra, and 6 months later, that is her glucose control. The initial HbA1c was 90, now it's 55, and we are talking about this, we're going to use the term time in range. So time in range, we're going to go beyond HbA1c. It's a time spent by a patient within normal range, and it's significant. It's a terminology which will be used more and more in the future, so it's part of that. And if you look at this patient, by using the Freestyle Libra, which is continuous glucose monitoring, we are able to monitor patients remotely to see how they are doing in terms of diabetes control. And the technology is given to them for free. The indication for Freestyle Libra or continuous glucose monitoring in our patients, or type 1 diabetes patients that are given continuous glucose monitoring, they qualify for that unless they don't want to use it. But also, we have got type 2 diabetes patients who are on multiple injections. The definition of multiple injections is 2 injections or more. So we tend to get some of the type 2 diabetes patients who are taking oral therapy initially, at the end they end up taking insulin, they qualify for technology and therefore give them the continuous glucose monitoring, such as Freestyle Libre. Initially it's costly, but if you look in detail, it's cost effective in this case, because if you get a patient who's using Freestyle Libre, you reduce recurrent admissions, you reduce complications such as hypoglycemia. The Libre has got a sensor for hypoglycemia and for hyperglycemia. And most importantly, most of our patients who have taken the technology, their quality of life has improved. So that's the most important thing, that these patients, they get a good quality of life, especially previously, like my patient, she was keeping her glucose levels high because of fear of hypoglycemia, and therefore history of recurrent admission with DKA. But by having a technology, she's able to set an alarm. If she gets hypoglycemia, the alarm sets off, and she's able to act upon to take anything to try and correct the hypoglycemia. I'm a member of Diabetes UK, and we do charity work. And I did the London Bridge walk, which is about 12 bridges in London. So Diabetes UK is part of a charitable organization. They fund research, and we are, as a healthcare professional, we work with them, and they support us. And as a partner with patients, we've got a lot of resources from Diabetes UK, including literature, but also patient education and so on. So in summary, I've talked about a patient who is non-type 1 diabetes for almost 30 years, her clinical presentation, but most importantly is about the use of technology in these patients to support their care and to improve their quality of life. And I hope that with collaboration and partnership scheme between our institution and Tanzania, I want to see that a patient from Tanzania who is type 1 or type 2 on insulin, they get access to technology, including insulin pump as well as Freestyle Libre or continuous glucose monitoring.
Much, Professor, for really excellent presentations. Now I think all the presenters to come. All presenter, we have Dr. Kanbai, Professor Dina, Dr. Faraja, and Prof. Mlawa. Please, if you can come in front, and because of time, we'll take only maybe 3 or 4 questions. It's only 5 minutes, so make sure that your questions are very short and focused one. Yeah. So you're welcome, please.
Thank you. My question goes to Dr. Kuzema. You talked about the acute coronary syndrome, and you highlighted that there are only 6 centers with the cath lab. But again, with unavailability of thrombolytics, what is your comment on your use of statins, antiplatelets, anticoagulants, and beta blockers to STEMI patients? Thank you.
Yeah, thank you very much. So when it comes to acute coronary syndrome, I think my senior colleague just said that medical management, when a patient comes into an EMD, what are the primary medical management you do? So the guidelines, what it suggests that if you identify an ECG that's an acute coronary syndrome STEMI, which is an ST elevation myocardial infarction, what you need to give is that you need to administer one is that you give them 600 milligram of clopidogrel, 600 milligram of aspirin. You give them high dose statins to stabilize the plaque, which is a vulnerable plaque which might have ruptured. And at the moment, we don't give beta blocker in these patients as a guidelines. Guidelines just says acute coronary syndrome you manage with aspirin,
aspirin, clopidogrel, or prasugrel, or ticagrel, and you got your statins on. And it depends that if the cath lab is within 90 minutes of the reach of the patient, then you send them directly for primary PCI. But in our country, we can't manage that 90 minutes time. Even in Dar es Salaam, sometimes the patients delays due to financial constraints to come and have a primary PCI, because primary PCI has a cost. And that's why what we are advocating is that primary thrombolysis is the way to go in our country to start with, and then do a facilitated PCI in our country. So yes, aspirin, clopidogrel, prasugrel, ticagrel as a first line medical therapy is there, but that is just a protection to stabilize those plaque. Or if you see what my senior colleague talked about, the ICE study, which was done in late 80s, which said that even aspirin was having a mortality benefit. So by administering an aspirin to a patient who comes with a chest pain in acute coronary syndrome had a mortality benefit, and there they compared aspirin with streptokinase, which had got mortality benefits. So thrombolysis was the way to go. Now that as we are advancing and we have got multiple cath labs in the country, we know that we can save these people by giving them a primary PCI. But up-country's patients need thrombolysis first. So yes, you start with your initial aspirin, clopidogrel, your statins, and your thrombolysis. Then you transfer the patient to a facilitated PCI to a PCI-capable center. Thank you.
Excellent. It was very
Hello. Yep. I think 4 really, really great talks on really, really important topics, highly prevalent diseases both in Tanzania and in the UK. Just a question to the panel. Just to summarise and draw the session to an end, any last comments about how we can move forward together? What's the low-hanging fruit? What are the easy wins that we can aim for as a starting point coming from this session today? So I think cardiologists first, and then the endocrinologists.
My understanding is that in Tanzania, as in many low-income settings, you're getting a double whammy. You're still looking after infectious diseases and the diseases of poverty, but you've got the chronic diseases coming very rapidly towards you, like because of diabetes, the Western diet that is infiltrating your populations as well. And I suppose one thing you could do is, in the knowledge that that's the case, is do everything you can to educate the population on diet, exercise, healthy living as much as possible to try and prevent the rapid increase in these chronic diseases. I think one really good thing that we've noticed whilst we've been here is there seems to be very little smoking. So at least you're not going to be hit by COPD in the same way as we are, perhaps.
Yeah, I think we agree with this, and I think we encourage exercise. We advocate exercise and as a part of our program at Jakaya Kikwete Cardiac Institute. We do campaigns. When they do campaigns, there is also something called Tembeana JKCI, means Walk with JKCI. So it's just to prevent NCDs, because we said prevention is better than cure. So there, yes, we are advocating with Ministry of Health in partnership. Recently, our Prime Minister has opened a way and closed our bridge for the cars every Saturday morning to do exercise for preventing NCDs as well. So yes, initiative has been taken up by the ministry level as well, and everyone is getting into it, that exercise is important with a healthy diet. So hopefully we'll be getting them. Yes, thank you.
I think from today's meeting, as far as NCDs including diabetes is concerned, I think my message would be to say that we have to maybe empower our community health workers, i.e. at a primary level, to try and educate our patients. If we empower them with knowledge, they'll be able to identify these conditions earlier, and at least we can prevent acute presentation of these conditions such as DKA or HHS.
Thank you very much. I agree with all what has been said, and on top of that, I think one of the other issue is to know what works, And this we can only know if we have a way of evaluating our programs. Because it's not uncommon to establish programs even at a national level, and then we don't know whether it works or it doesn't work. And then we see the next International Diabetes Federation prevalence of diabetes 12%, 13%, So I think it's very important in all the programs that we start, whether it's at a local level in our hospitals or at a national level, we really put a rigorous way of evaluating them so that we know if it works or it doesn't work, so that we tweak it or we find other ways. It's very impressive how you see data being presented on things that sometimes we feel they are very simple, but it was maybe a matter of reorganization, maybe it was a matter of changing the way we practice that can lead to results. So I think I will encourage everyone in all the levels, from the local level up to the national level, to have that habit of evaluating whatever we are doing to see whether we are getting positive results or not.
Brilliant, thank you.
Yeah, thank you very much. I think now you can go back to your seat, and let's give a round of applause we can give 3 strong tradition clap. Thank you so much. Yes, over to you now.
Thank you very much, presenters, for finally getting us through the marathon. We're done with the final block for today. Thank you, our dear moderators, Dr. Kisenge and Dr. Mandip. Thank you very, very much. I would like to invite Dr. Hamad Nyembea to head the roundtable discussion.
Yes, yes.
Okay, good evening. As we are about to wind up, this is the last session. Our last session is about roundtable discussion, and the main aim of this roundtable discussion is, after a day-long marathon, which was very busy. Now we need to come up with a very straightforward strategic plan on how we'll be able to implement our Tanzania-UK collaboration. So on this, we need to have a theory of change that will reflect on a result-based planning and implementation. And over time, of course, it will be also required to be able to measure the outcomes on the improvement of patient clinical care. So we'll be having 7 discussants that I will call them to come in front of you, so that they will be given 5 minutes each to discuss on this general topic about our memorandum of understanding between our countries, so that at the end we have a strategic plan on the implementation. So we have Professor Abel Makubi, who will be partnered with Professor Andrew Dina, and they will be discussing also Professor Bryson Kiwelu. They will all discuss about how we can strategically make a plan to collaborate on clinical care. So please, may you come to the front. Also, we have another pair, Dr. Kisenge and Dr. Anjun. They will discuss and give us the insights on how to collaborate and, of course, make a plan on the clinical research. May you please come. Again, we will also have another pair, Miss Catherine Halford, a clinical chief, and Dr. Khadija. This pair will give us the insights on the collaboration on the clinical governance. Okay, so to start up with this marathon, this is a small marathon. They will be given 5 minutes or less, if possible, and we will need to hear from them the insights on these subtopics. So to start with, I want to welcome Professor Abel Makubi to give the insights about how to implement this, are we going to plan strategically and implement the MOU on the case of clinical care between our countries. Welcome, Professor.
Thank you, Acting Director of Clinical Services, Dr. Nyambe, colleagues. I want just to highlight one thing before I comment on this topic on how we can collaborate on clinical care between the UK and the Tanzania institutions. And this is about the MOU. The MOU was signed last year, and so now it's almost 1 year in place. And it covers all the major topics for our collaborations, the way I understand it, when I was in the ministry and when we designed it at the initial stage. So all these components which you have already mentioned are part of the MOU. So now, as you have said, we need to see how we can collaborate with our colleagues from the UK. But also, the other thing that I want to highlight here, this MOU was not only between Tanzanian institutions and the UK institutions. TUHEDA was also a part of that, but also the UK government through the Tropical Health Education Fund was also part of this MOU, but also the Ministry of Health on our side, and also this MOU is being monitored by our embassies, our ambassador from the two countries. So, and one of the proposals was that to be able to implement what we think is feasible between our institutions, we needed to have a steering committee. And already, I think the Ministry of Health has established members of the steering committee. And I am aware Dr. Adija is our coordinator on the Tanzanian side. And already we have been communicating with our UK partners, and we have done several meetings in between through this partnership. So I think already, for this year, something has already been done. And when it comes to clinical care, now to focus on what I've been told to discuss with my colleague, I think we have already started doing things also on that part. MOI is one of the institutions which has taken the lead on that. And as I said initially here, this year we visited UK, and they were able to visit some of the UK institutions, including Queen's Hospital, Cambridge, Oxford, Manchester, Imperial College. And in those visits, we were able to see what are the areas of common interest in terms of clinical care. For the Tanzanian side, I think the way I understand the health sector, our major gap is how we can build the capacity on clinical care for some of our specialists. We have seen the presentations from our colleagues here. We need to fill up some gaps in some of the areas which we have already qualified, just to make us more more skilled. And that's what we've been demanding from the UK side. They are more advanced in some of the areas, so I think we can expose some of the clinicians through clinical attachment, through exchange program. For instance, the UK team may visit us here, and we can have something like a camp where we can prepare some patients to be able to either to operate or to just to review them and make decisions. So through training of our clinicians, through clinical attachments, through camps, medical camps, those are some of the areas that we can think in terms of clinical care. We can have something to partner. So to be able to succeed, I think each institution here in Tanzania has to identify a partner from the UK side in the area which we think we have common interest. And it can be any specialty, maybe neurology, emergency medicine. And we have seen from the presentation that emergency medicine, for instance, is one of the gaps that we have. We need to train more people. We have a lot of gaps, cardiothoracic surgeries, cardiology, neurology, orthopedics also, but also other specialties can be part of this. This is not a limitation for that. We can open for any kind of specialty which we think we in Tanzania we need some support, but also the UK team also can learn a lot from us in terms of clinical care. And I think if we can sit together and be able to identify those institutions, I think we may be able to progress further and be able to collaborate in more specialties in clinical care. So that's what I would like to comment at the moment. Thank you very much.
Thank you so much, Prof. Yes, Professor Endrodina.
Right. So to add to that, I think we've already started a series of grand rounds, virtual grand rounds, with colleagues, mainly in Zanzibar. We could extend those, obviously include those on the mainland, but also where it's felt that it would be helpful, have more specific clinically based MDTs to discuss difficult and complex cases, where it's felt that our expertise would add to the management of individual patients. I think that's one possibility. In the realms of education, some of us have quite good experience in developing education programs. I was involved as head of postgraduate education in medicine in London. I was head of the School of Medicine for a number of years, and we have experience in curricular development, annual appraisals of trainees, making sure that they're fulfilling the curricular requirements, supporting them when that's not the case. And we could help you with that, perhaps through the new, I think it's the East, Central and South African College of Physicians, because I know they're beginning to develop your own Africa-based curricula, and I'm sure we could help with that. Then there are possibilities for service development. So I've been working with the Institute of Cardiology in Uganda, and we're about to run a program supporting them in developing cardiac MRI. But there are so many other areas that we will have experience in which we could share with you and help support. Then there's the whole area of research cooperation. We've already talked about that to some extent today. I'm interested in maternal cardiology, for instance, and there's I suspect a significant need for extra work on looking after women with unsuspected cardiac disease who become sick later in pregnancy. As mentioned just before, having visiting fellows come to the UK would be useful. We have the MTI program, the Medical Training Initiative, where trainees are sponsored to come across. They get paid the same wages generally as our own trainees, and they get hands-on experience, but they have to go through the appropriate registration systems. That's more difficult for non-doctors, but I think that there has to be a way of supporting nursing development and the development of what we call associated health professionals like physiologists, radiographers and so forth, which I think is something that's not so well developed in low-income settings. And then and we could think of a whole series of things. One comment I would make is that yourselves, with our support and many medical communities within low-income settings need to put pressure on pharma and technology companies. I think it's really unfair that you have to pay the same for medicines in a country like Tanzania that we are paying and often struggling to pay in wealthy countries. We talked about SGLT3 inhibitors earlier. They're £30 a month in the UK and they're £30 a month in Tanzania. How can that possibly be spread to a whole population when your GDP is so much lower than ours? So I think either there has to be pressure on pharma to discount to low-income settings, or there has to be a push towards developing your own manufacturing bases to manufacture these drugs and also manufacture some of the technology. I know it already happens in India, and that would be a way of allowing increased access to modern technology, modern pharma, and your population has just as strong a right to have access to that as ours. And needs to be a way found to make it more accessible, more affordable.
Okay, thank you.
Thank you.
Yes.
Thank you very much, Chairperson. I concur with all what have been said by the previous speakers. Nevertheless, based on the memorandum between Tanzania and the UK, I remember it started the way back in 2018 when we met with Professor Mlawa for the very first time. But it took almost 5 years for memorandum to be signed. And this is because actually the very same people are doing some other things, and at the same time they're making follow-up to make sure that the MOU is working. So I suggest to have a kind of a permanent office in the country with the permanent staff who will be working only on this MOU, because the MOU has a lot of areas that needs to be worked on. So those people should work on daily basis by putting together all the stakeholders, by starting with preparing the 5-year strategic plan, because the MOU was signed in 2023, and it's going to last for 5 years. So we need to have a strategic plan for the next 5 years. And out of that strategic plan, we need to have an annual operational plan. In that annual operational plan, we need to map the area which we need to collaborate, because we cannot just hit everywhere. We need to have the set of areas which are of interest for both parties, and out of them we make an action plan, and we prepare budget, and you know exactly who is going to fund these particular activities, and we know exactly when are they going to take place. By so doing, it means we can have a lasting impact out of this MOU. For instance, in the clinical area, we need to have kind of a blended learning, whereby for most of us in Tanzania, we prefer to have some lectures and hands-on skills. That's the best way we learn, by doing. And it's better that the experts from UK, they come and work with us here in our hospitals. So we have to establish a list of hospitals in the UK who are willing to participate in this kind of partnership, and then to link them with the hospitals in Tanzania to have sister hospitals to facilitate the exchange programs. And if there's a possibility, we need to have clinical skills laboratories in each region, in each zones, so that we can have hands-on skills. And for the sake of training, especially we can link the kind of training that is offered in UK with the Tanzanian scholarship, which is offered every year, so that the clinicians who are going for postgraduate studies, they can go to UK, and the government of Tanzania can pay, because there's a mutual understanding between the two countries. So they can go there, they can learn. And some of them, if they wish to stay there, it's okay, because it's a mutual benefit, like Professor Mlawa is there now. So we can benefit, because now Mlawa is there and he's coming back to give back to the community. So we have to have kind of a mutual relationship. So far, that's what I think.
Okay, thank you. So another batch of discussants is on clinical research. So may allow me to welcome Dr. Anjun.
Yep. Yeah. So I think it's a big question. Any development of clinical research is going to take resource, people, time, and money. So I think there needs to be a strategy for what you want to focus on, and that's probably be from a national level, regional level, and then institutional level of what kind of areas you think are important to research, and that will, I'm sure, piggyback onto what you feel your clinical areas are that you want to develop most. Then I think in those areas, your specific research questions, and do you have the data to back them up? I think in some areas we've seen today that there is good data, and in others there may not be. So is some of the work that needs to be done initially audit and service evaluation to then go further and see what research questions you also want to answer? In the UK there's a whole administration infrastructure of how clinical trials and research is regulated, making sure the ethics are correct, and the governance is there. So it's a big project, but there are organisations in the UK that I'm sure somehow we can be able to collaborate. Interesting what Andrew said about the pharma. We have drug trials in the UK. Drug trials can be, maybe we need to put pressure on to see, to have these trials to answer the questions that you have in places like Tanzania. And I'm not sure how we do that, but that's what we would need to do. And then, so if there are identified areas, our institution may have links for some areas of research, but I'm sure we could also collaborate and try and make contact with other people where there are areas that maybe we aren't so involved with research that you want to be. So I think it's about really initially working out exactly what you want to develop, because unfortunately you're not going to be able to do all of it straight away. So it needs to be a strategy of what you want to do, and then we can work on that.
Yeah.
Okay, thank you.
I think much has been said by Professor Makubi and the others. To my side, really, I need to, maybe we can put much emphasis on the disease registry. If we can collaborate and start having registry, for example, in cardiology, we might need to build up a heart failure registry, MI registry, and we can adapt from your registry in UK, and then we can bring in our local environment. So we need to define an objective and a scope for this registry. And I know we have already partner. This is a partner. We need to discuss with them here, and we can come up with implementation for those, what we've just discussed today. Because if you look what we've been discussed from diabetic, from heart disease, from neurosurgery, I think we can shortlist whatever we've discussed today, and this will be a starting point. Yeah.
Okay, thank you. Thank you, Dr. Kisenge. Our last batch of discussants will be discussing on clinical governance, the collaboration of clinical governance between these two countries. So allow me to allow Ms. Catherine to give us her insights.
Thank you. So I think clinical governance is an enormous area and an enormous topic. And in the sort of 15 minutes that I was talking to you, I talked about two specific areas. That was safe staffing and ward accreditation. And my suggestion would be that we start with that. That's relatively straightforward to do. There is already quite a lot of work that's being done in some hospitals around clinical incident reporting, and that all builds into that. So my advice would be, there's masses to do, but but you can't do it all at once. So do the things that are going to make a tangible difference relatively quickly, that you can consistently deploy across a number of organisations across Tanzania, and use that as the benchmark, because if you try and do everything, I just think it's going to be really, really hard to do. So I think that I would have access to the data, the information, the tools that would enable you to start some of that work relatively quickly, and I would be happy to participate with that. And then I think that once that sort of thing is embedded and you've started on that journey of governance, understanding what governance means, then you can move into other areas.
Okay, thank you. The last one is Dr. Khadija, please, for your insights.
Thank you very much. Catherine and I were asked to talk about clinical governance. And I think the whole things we've been talking about and the whole MOU is basically clinical governance. Catherine mentioned that it's quite a wide area, but I would like to mention to you some of the components that make clinical governance is maybe a better definition of what we want to embark in the next coming years. Because the clinical governance is essentially responsibility and setting up standards to optimize care, safety, allocate resources, pursue continuous improvement. And when you do that as a clinical governance strategy, you actually embark on improving quality and safety, risk management, performance measurement, evidence-based practice, also education and training, and leadership and change of culture towards a better culture for clinical outcomes. So that basically is clinical governance. So I'm thinking that if we start where we are right now without taking stock of what we have, we wouldn't know if we're going or coming back. So one of the key things is we need to take stock of what we are. What do we have? Where are the unmet healthcare needs, where the clinical governance that is falling short, or whatever it is that with the health problems, we need to take stock of what is our status right now. And then we set up a theory of change. Dr. Nyambea mentioned a theory of change, or maybe a logical framework where it would show us where the gaps are, what do we need, who will be willing to work with us, and I understand we have the partners already. And then we put up inputs. What are we going to need? We might need funding, we might need human resource, maybe not set up a new office. I'm not the best person to say that, but then I think we'll have a plan. How are we going to do it? All what has been said is actually being done everywhere within different institutions here. And so we bring in the best person as the liaison, and everything on will go on, and then we'll have our indicators. How are we measuring up? This is where we are. At the end of the day, we'll have results with indicators that can measure how far we've come from, and then we'll take it from there. So Dr. Kiwelu, he mentioned about, you said a strategy or something, a strategic plan. We could have an action plan, but it should be measurable, because it's the governments that we're talking about. They need to budget for that. And for them to say, we have done this, this is the impact, we have saved a certain number of lives, we've improved clinical care, and that model will cascade to the regions, and NHS probably will you will learn a lot from us, I'm sure, with the medical anthropology and everything else, why we're behaving the way we are. And I think we will have done a good job. Thank you very much.
Okay, so thank you very much for your insights. I want also to engage the audience. So please, anyone who like to give insights on how we can collaborate and so implement this MOU. At least 2 to 3 people. Welcome.
Thank you very much, and I'm so very happy to have this opportunity. My name is Juliet Kabirigi, a pediatric cardiologist from Bugando Medical Center. Yeah, from what we have been discussed, for sure has a lot of impact, especially on my clinical work when I go back home. But I have few concerns concerning the maybe if we will be fine in future, this symposium, UKTZ symposium, to be done at the regional level, for instance in Mwanza, because this will bring the art of ownership and sense of responsibility that we know that UK Tanzania also is ours. You know, for instance, the Lake Zone, we are saving more than 14 million people. And there's a lot of issues. We are working normally to save like a low-hanging fruit. For instance, in our Bugando Medical Center, we are doing PDA surgical closure because still we don't have a cardiopulmonary bypass machine, but those people, they need us. So we just looking around and to see what can we do to these innocent souls. So I'm so happy because this platform, it will be very good because many people, Professor Makubi is one of the witnesses. We have non-communicable disease, a lot of them, from sickle cell, congenital disease, at the top of congenital anomalies, especially in children. And now we see a rising number of congenital disease even in adult population. So I'll be very happy to see UK Tanzania Symposium to be done at the regional levels also. But I wish also to have representatives at the regional levels. And because only in at the level of the Ministry of Health, I think it will be good also at the regional level as representative. It will be simplifying the work, maybe on Zoom meeting, maybe to bring some reports, maybe to know more what is happening at that levels. Thank you very much.
Okay, thank you. Next, another. Yeah, we have another three. Okay. Yes.
Thank you very much for this very important symposium. My name is Robert Alois Malia. I'm a critical care nurse. I'm coming from JKCI. I'm working there as a nurse, but also I'm the director of clinical nursing services. So I was really impressed with a lot of the presentations, but Catherine touched me a lot about clinical governance, and I think we will collaborate more to see how we can improve on clinical governance and to maximally use the number of nurses currently we are having by improving on the clinical governance, and we will find the gaps and see how we can bridge them together. So I think Catherine, we have a lot to share, and after this, I think we will continue keeping in touch to make sure that we learn from each other. Thank you very much.
Okay, thank you. Too many hands. So
thank you very much.
Because of the time, maybe I will allow three more participants.
Okay. My name is Dr. Ali Akrabi. I'm an emergency physician from Bugando, the Lake Zone. I'll go direct to the points. I have 2 points. Number one is to have the openness. We should see the progress of this collaboration by communication loop, that we can form the contact loops like the email so that everybody is engaged. And in that way, we can have the monthly meetings either by virtual or by physical meetings so that we see the progress. And the Ministry of Health or any other tertiary institution may lead this or may coordinate this. So that is very important. But and number two is that we cannot grow the multi-specialty care if we forget the nurses. So the growth of the nurses or the nursing care is very important. That should go hand in hand with the specialty care. So, and that should not be entitled to one tertiary institution. It should be diverse, encompassing all institutions or the regional, especially the regional hospitals in the country. Thank you very much.
Okay. Yes, next.
Very much. My name is Amis Shabane, consultant neurosurgeon and the head of pediatric neurosurgery at MOI. The way I see this UK-Tanzania symposium today and collaboration, it reminds me of what started in India some years back. And now what we see, if you go down the literature and see how much publication is being produced from this UK-India collaboration. Actually, it surpasses all the collaborations which are done between the high-income countries and low-income countries. And what strategies India did was one thing: advertising India to UK. So what I encourage my fellow Tanzanian is that we should advertise Tanzania to UK. This is the only way institutions from UK can know what is happening in Tanzania and become willing to collaborate with Tanzanian institutions. We are happy that we have seen Queen's Hospital, many of them have attended this symposium, but I had wished big universities like Cambridge and the other one from UK, Oxford and elsewhere, to be here. But I'm not sure that they know there's a UK-Tanzania collaboration. I'm not sure. So how can we advertise Tanzania to UK? It is simple. Dr. Kisenge has mentioned it. Introduction of registry, quality improvement projects. This is the only way we can collaborate with institutions in higher income countries. So I encourage each one of us. It's not only the doctors, even the supporting staff. My colleague, Dr. Hadija, has mentioned it, and I don't want to repeat it. We start small, quality improvement projects. Even a small thing like inserting a catheter. How many times we insert a catheter and cause infection in somewhere? How many times we introduce high-end antibiotics to something which requires a simple antibiotics? You know, we start small, we advertise, and these institutions will be willing to collaborate with Tanzanian institutions, and we can have all these benefits of technology transfer and everything. This is what I encourage my fellow Tanzanians to take a homework.
Okay, thank you. Maybe one more chance. Time is not with us. We have negative 30 minutes.
Can I comment?
Yes.
Yes, thank you. I'm not for hard landing now, but I think we need to have like what we call plan A, plan B, plan C. We may have a bunch of things we want to do together at a time. This may not work and it may take long. You see, this relationship started since 2018, and today things have happened. How many years? So I'm thinking of simple things that we can do. For instance, we have seen the gaps. For example, in trauma, we know we have deficits in skeletal and soft tissue reconstruction. We can see, you guys, how many surgeons can have to attend to our hospitals. For instance, let's say Moi or Benjamin Mkapa. We do what we call reverse fellowship. Come stay with us for 1 week or 2 weeks, stay with us, we do something. This is how we can impart skills and knowledge. That's number one. Number two, we have seen the gaps in research which has been discussed. We have food on the table, but no one to eat it. So you guys, you are experts. So we think, let us use what we have now. We start as a small package, then we'll grow up with all these things. But if you go with the policies, trying to think of the budget and everything, we may take a longer time. That's my different thinking. Thank you.
Okay, thank you so much. I think this is the end of roundtable discussion. Thank you so much, Discanta. Sorry.
Lakini pia wewe utafunga official.
Mimi nitaanza hapo, atakuja yeye hapo na kumaliza.
Wageni wetu. Okay. All right. Thank you.
Good evening again. It has been a very busy day, but what was very impressive all time is to see people awake. That was very fantastic. As we are going to end up, we will end up like this. I will just have a short talk. Then I will welcome Professor Mlawa for a word of thanks from UK side. And then I will welcome Professor Makubi to have a word of thanks for Tanzanian side and to officially wind up our symposium. So starting with me, we have been here for more than 12 hours. It was a long but a vibrant day. And for me, based on our symposium topics, our discussions, I saw we have point of intersections between our two countries. We have areas of cooperations, and we have areas for common interest and the opportunities that we can harness together. So because of this, I think we need to find effective mechanisms to transfer clinical knowledge, to harness new technologies between our countries, allow technical exchanges between our institutions and our experts, and also streamline these processes for our institutions. In this case, Tanzanian side is willing to have one-on-one exchanges and beyond. During the first presentation from Tanzanian side, the organization of service delivery in the country, we saw the ratio of the public-private sector in health services. It is 96 to 31, 99 publics, then 31 private. So with this number, and of course with the government investment for the past 5 to 10 years, our big challenge now is on the quality of service. We are now struggling night and day to reduce the number of complaints from our customers, from the communities. And most of the complaints are because of the customer care or the quality of service. So in this area, based on the discussion today, I think is one of the areas that we can work together and see how we can improve the clinical care in our country. And of course, by designing the best basic management of health service according to our contextual basis. I cannot stop here, and of course I don't like to talk too much, but I want to convey my special congratulations to the following. One is to the organizing committee. They have worked very hard for the past 2 or 3 weeks, and we see today this symposium was spectacular and vibrant. So my sincere congratulations. Second is also a special congratulations to TUHEDA. TUHEDA, for really, it has been a special purpose vehicle for the UK delegation towards implementation of this MOU. They've been struggling for a number of years, first to ensure that this MOU signed, but also they went further to make sure that we have the first event, which is this symposium. So thank you so much to HEDA UK. Last but not least is special thanks to Professor Makubi. Professor Makubi is not now in the Ministry of Health. Of course, he played a part in the process of signing of the MOU, but because he is not no longer in the Ministry of Health, but by using other mechanisms, he also struggled a lot to make sure that this MOU become a reality and become into operational. So we also give special congratulations to Professor Makubi. He has been showing, and of course he is still showing, a strong patriotic sentiment for Tanzania. Maybe to wind up, I want to give a special chance to Professor Gideon Mlawa just to say a word of thanks for this event. And after your words, then I will welcome Professor Makubi to end up our event. Please welcome.
So thank you very much, Dr. Nyembea, for supporting us and the Ministry of Health. I think myself as a diaspora and also member of TOHEDA, what I want to say, we are part of the diaspora, but also we still want to give back to our countries of origin. That applies to most diaspora being from sub-Saharan Africa, West Africa, or South Africa. And with TOHEDA, we are able to do that. And what I will ask in terms of in-country institutions is to take this opportunity to work with us. We are just the facilitators to enable collaborations, and therefore our institution locally have to take the chance. I heard the people from Bugando with regard to regional involvement. We have got a network, we've got TOHEDA as membership. We run webinars from time to time, even between TOHEDA members within the diaspora, but also with Tanzania. And therefore, we should get our contacts so that you can be part of that process and you'll know more about what we're doing on maybe month-to-month basis and what is happening in future. But I want to thank the UK delegation for supporting me, because my colleague from UK, they've taken their time off. They paid their own fees to come to UK, including flight and accommodation. And that is a testimony to their commitment to try and support what the diaspora are doing. And therefore, I'm very grateful for them for supporting us. And we have got in-country TOHEDA members. Dr. Hadija is a member of TOHEDA in Tanzania. Professor Makubi is an honorary member of TOHEDA. And Dr. Kunda, who was here today, is a member of TOHEDA. So we've got TOHEDA members not only in UK, but also within the country. And we are working together with them. And before we came to the country, we've been in constant communication with them with regard to this summit. And I think the success of this summit isn't because of TOHEDA alone, but also because of within the Ministry of Health and the local or in-country TOHEDA members supporting this. So in summary, I would say that TOHEDA, we are here to facilitate in a collaboration, and whenever there's an opportunity for us to try and seek opportunity for our institution from Tanzania, we will do so, but we also want your commitment and the collaboration. Thank you very much.
Yeah, thank you, Professor Mlawa. Habari za jioni. Good evening. I know that you are a bit tired now and you need to have some rest, but I'm going to just spend like 5 or 7 minutes of yours from now just to give a few remarks on the closing moment of this symposium. The Acting Director of Clinical Service, the Assistant Director, directors from the hospitals and also from Muhimbili University, directors from private hospitals, all participants. May I take this opportunity again to thank you very much for being actively participating in this workshop. This symposium has been really an eye-opener for us who are working in hospitals, also in medical universities, to see how we can utilize the opportunity for collaboration between our two governments. When I was giving my speech before inviting the guests of honor, our deputy peers, I said that this collaboration was actually supposed to happen maybe 5 years back or 10 years back, because we need to work with other countries as Tanzanians. We cannot just work on our own. So the Minister of Health for the past 3 years has taken all these efforts to be able to sign this MOU. And I'm happy that now we have a steering committee under Dr. Adija Malima. So all institutions are now can be well coordinated, and we can have a common track on how we can implement the current MOU. So I just want to urge my colleagues from hospitals, from universities, from public and private hospitals to utilize this opportunity effectively. The UK government, the way I see it, is really committed. That's why we spent almost a year discussing the MOU. They just want to know if we are really committed to implement it. So we should not disappoint the two governments, our presidents. Our President, Honorable Dr. Samia Suluhu Hassan, want to see that we are able to collaborate with the other countries for the interest of our nations and for our people. And this is what our minister also wants. Honorable Umi Mwalimu wants to see that we're open to other countries, so we should be able to use this opportunity effectively from now. I understand some of our clinicians are very difficult to collaborate with others, but we have to change. For academicians, it's very easy because they are used to that. But for clinicians, they just want to work on their own. We have to stop that a bit. We have to open our eyes, we have to open our minds and work with other colleagues. Team working should be our priority, either locally or internationally. If we don't change, we're going to lose a lot of opportunities. I know in Kenya they have utilized this opportunity very much. In Uganda, the same thing. So I think Professor Mlawa, thank you very much with the Header for being able to push things, to be a catalyst for this collaboration. So now, it's for us Tanzanians to be able to struggle and work hard and commit ourselves on what we want to collaborate with the UK teams. When I was in the UK in April, even last year, people are ready to support us, but we have to be committed. Yes, my colleague Dr. Shimon was mentioning about advertising Tanzania in the UK. That's a good thing. So even that kind of approach requires a lot of commitment. So I understand if you are able to utilize this opportunity effectively, we're going to have positive outcomes for our people and for our patients. Clinical care is one of our priority. Research is the second priority, but also training and also availability of equipment. So if we can pair with our colleagues on a common area of interest, I think the two countries will benefit from one another. So with those few remarks, I want to ask my colleagues, when they go back home, let us try to think about how we can use this symposium as a bridge to be able to establish international collaboration with the UK institutions. I also want to thank my colleagues who have come all the way from the regional hospitals. I have seen a number of them here. Asante sana ma medical officers, tunashukuru sana mmeweza kuja hapa. Since I've been in the sector, I'm now seeing here now the medical director for our regional hospitals being invited to come to this very serious meeting. Congratulations to the Minister of Health for being able to take into consideration of this. And this is the way we can work together. National hospitals cannot just work on their own without being close to the regional hospitals and the district hospitals. So now we are building a network of research and clinical care from the top to the lower levels. And that's what the ministry wants. We as directors, we have to be able to implement it. Also, I want to thank all the presenters who have managed to give a lot of presentations, very constructive, very informative. So it's been really a very good symposium with good updates on a number of subjects and the topics. Thank you very much to the presenters. Allow me also to thank our colleagues from the private sector. I have seen some of them here, like Aga Khan and other colleagues and other institutions. I think the public sector has to work also with the private sector. So this is another good partnership between the public and the private sector on how we can engage our friends from outside, being as a one partner in this country. But also want to thank our Minister, Honorable Umi Mwalimu. So on behalf of all of us, I think she has done a lot in this sector. So let us really thank her for her commitment. Together with the other technical teams. And lastly, this meeting has been supported by our institutions, Moi, Jakaya Kikwete, MNH, and the Ocean Road, as well as MOHAS. Thank you very much for your contributions. To head, I think tomorrow are leaving to Zanzibar, I think. So I want to promise you that we as institutions and our steering committee, under the coordination of the Minister of Health, we are really committed to implement what has been proposed from this meeting and from the MOU. So continue pushing for the positive outcomes when you go back, and we are ready to see that the MOU brings positive outcomes to our people and also to the UK teams. Lastly, I want to thank everybody for coming to this meeting, and I hope maybe next year we can have another meeting, whether in here, in Dar es Salaam, or in Dodoma, in Mwanza, or in Mtwara, or in the UK. It depends on where it's going to be feasible for us. But let's plan to have another meeting next year. I think that can cement our collaboration. So with those few remarks, I want to now, on behalf of our Director, Clinical Service, to close this meeting officially. Thank you very much.
Good evening, everyone. Thank you. You've been a lovely audience. It's been a pleasure being your Master of Ceremonies for today. Just 3 announcements before we depart. 1, there is live music and a lovely, lovely dinner waiting for us. Just follow the music. It's by the pool, I hear. For those of you who have not signed in your MCT numbers for CPD points, please do so with Dr. Zarina. And Dr. Manpreet had a short ultrasound workshop. It's going to take a few minutes. She just wants to show some piece of equipment she has. So while we're mingling and going for dinner, we can just meet her. Thank you very much. Good evening. Get home safely. Good night.
Just